Looks pretty good right now, Rex.
Look at all these other sites that are on right now too.
Well,
And,
your lost packet just jumped up.
Yeah. Callaway County looks pretty bad. Most part looks pretty decent. Well.
Okay, good morning, everybody. Appreciate you bearing with us on ITV out there. We've had a few technical issues this morning, so hopefully we've gotten those resolved, and we'll be ready to get going here now. Appreciate everybody joining us this morning. I know that we've had last week with KPHA, a lot of people traveled a lot last week. And so we've got probably more on ITV this week at this meeting than we normally would have. Again, I apologize. We normally have the CADA meeting with the KPHA conference, and I know for several of you that always works out well. And unfortunately, due to timing issues, we were unable to accommodate this year on that Monday. But there's still several directors. I think it worked out well. We was in Randy's room there, and I think there's almost 30 public health directors there that met to discuss issues. So I think we were very productive, but maybe that's our problem. We have too big a meeting space. We need to see how many we can get in the phone booth and get things done, right? So appreciate everybody. So just so to verify here, Allison, I see you all, and Kayla there. Can you give me a thumbs up? Are we broadcasting okay via ITV? Okay, good deal, good deal. Okay, Jill, will you go ahead and call the roll, please?
Before I do that, we have one item from KPHA conference, silent auction, that was not picked up. Well, we have 4 items, but one of these, it's an employee of MCHD. There actually are 5 MCHDs. So I wasn't sure which one it was, Montgomery Martin. It's Lauren Smith. So if that's your employee, please let them know. Lauren Smith won a picture frame at $7. Or if you're here as her employer, please let me know. Thanks. Allison Adams. Present. Paul Alexander. Here. Denise Beach. Here. Andrew Beckett. Here. Anita Bertram. Allison Bashir,
Here on ITV.
Sarah Jo Best,
Here on ITV.
Renee Blair, Brent Blevins,
Here.
Russell Briggs, Crystal Caldwell Miller, Linda Cavett,
Here.
Jan Chamness, Dennis Cheney,
I'm here. Couldn't find the mute
Dennis
button.
Cheney on ITV.
and Jan, okay, thanks. Karen Cooper, Noel Copeland,
I'm here.
Tony Cox,
I'm here, ITV.
Sean Crabtree,
Leah Jasper, I'm serving as Sean's proxy.
thank you. Nancy Crew, Bobby Kreider,
I'm here on ITV.
Kathy Crown Weber,
Here on ITV.
Chris Crum,
Here.
Debbie Stillman, Donnie Fitzpatrick, Jill Ford,
Here, ITV.
Teresa Gamsky, Randy Gooch, okay, Tim Gould,
Here.
Maria Hardy, Jen Harris,
I'm here.
Georgia Heiss, Mark Hensley, Marsha Hodge, Teresa Hunter, Becky Keith,
Here.
Kent Coster,
Here, ITV.
Dr. Rice Leach, Susan Lyford, Scott Lockard, Tina McCormick,
Here.
and I know Gigi Meredith is here, but she can't speak, so I've got her here. Deborah Miller,
Here on ITV.
Kathy Neal, Dr. LaQuandra Nesbitt, Mark Pyle,
Here on ITV.
Dr. Raphael Rangel,
Raphael Rangel.
sorry about that. James Ratliff Jr., Andrea Renfro, Lynette Renner, Melissa Royce, Dr. Lynn Sadler,
Here.
Sheila Sharp, Dr. James Pete Shepard, Scott Shrewsbury,
Present by ITV.
Thursa Sloan, Paula Thornberry, Gail Temperio, Tim Wright.
Is that right?
That's-
Okay. Thank you very much, Jill. Okay, the minutes from the previous meeting went out. Were there any corrections or additions to the minutes? None being stated, may I have a motion to accept the minutes as they were presented? Okay, motion made by Mark and seconded by Russ. Okay. Any further discussion? All those in favor, so state by saying aye. Opposed, nay. Okay, minutes stand approved. Thank you. Our treasurer couldn't be with us this morning, so we're going to table her report till our next meeting. And then our executive director's report. Steve.
You all should have received an email report yesterday. I guess I really don't have anything to add to it. I will be sending out, working with the legislative committee, full legislative update. There's not a lot to add to a legislative update that candidly hasn't been in the Courier Journal or the Lexington Herald. I think everybody pretty much knows what passed, what didn't pass, what didn't get discussed. I think the biggest thing that's got some activity to it that's hanging over from the legislative session right now is the heroin bill. And I talked a lot, and I think later in the meeting we might talk about it for a few minutes with the under Scott's section. But I talked a lot at KPHA with various people from Three Rivers in northern Kentucky about follow-up on the heroin bill. And I'm ex officio member of the Substance Abuse Board because of khda. So I'll be working with them from the executive branch side, see what they're thinking about doing on addressing the heroin issue before the next legislative session. I know there are a lot of people from, again, Three Rivers in northern Kentucky and probably other health departments, but I know that at least those two are very actively working on what was Senate Bill 5, and so we'll talk about that later in the meeting, just to make sure all the health departments, I have an understanding of where folks are coming from on the heroin issue. Beyond that, I'll be glad to answer any questions that anybody has or discuss anything with anybody. I got it?
Okay. And right now is probably the best time. Let's just go ahead and delve into the heroin bill, Senate Bill 5, and have that discussion right now. One of the big issues, and Steve is very well versed on this here, one of the issues that was going to have the biggest impact on health departments, there is language in Senate Bill 5 that was inserted regarding needle exchange programs. So health departments would be the sites in each community to do needle exchange. And I know this, whenever you say needle exchange programs, that some people feel very strongly that is a great public health initiative there to cut down on the spread of disease. Other people are concerned, there's red flags that pop up. Are we going to have security issues at our health department? What's this going to look like? So we need to be well versed and well informed on what this would look like. But Senate Bill 5, one of the reasons that it did not progress, there's a myriad of reasons, a lot of them political, but one of the issues there with it was it really focused a lot more on the punishment side, and I think, even the ardent supporters of Senate Bill 5 wanted more on treatment and some expansion there. But again, our biggest issue would be needle exchange programs. And, of course, there was no appropriations attached with it or anything like that. That would be seen as our public health initiative. And as we are starting to work on this, is that something that, if we are to run needle exchange programs, are we going to try to advocate that there be an appropriation attached so we can effectively do this? Are there, what are, the parameters there that we would be comfortable with needle exchange programs? Or but we see these across the country and other sites. So, Steve, I'll let you expound upon this.
Well, I do personally believe that there's a very good chance that in some way, shape, or form, the heroin bill and the heroin subject is not going to wait to another legislative session. There's going to be a lot of activity. There might not be anything the executive branch can do without a legislative session, but you already had the president of the Senate, Senator Stivers, saying he thought it was worth $500,000 for the legislature to come to town for 5 days and get a heroin bill passed. Most of what went wrong at the end was, as Scott referenced, the politics. I mean, a part of it was the last bill that they were going to deal with in the session, and every single amendment in the world, every single piece of legislation that didn't get passed, that anybody was in favor of, they tried to get it added to that bill as an amendment. So it became a bill that kind of didn't, in addition to doing whatever it did on heroin, kind of had tolls for going across the Ohio River Bridge, all kinds of other things that were added to it, so it just couldn't even ever get voted on. That said, obviously it's a problem. From my perspective, from everything I've read, it's not a problem unique to Northern Kentucky. It's a statewide problem. It certainly seems to me like it's a problem in Frank County just from reading the paper every day. And I just really believe minimally that the interim committee on health and welfare and or the interim committee on judiciary will be bringing it up, talking about it, and the legislative group from CADA and KPHA didn't really take a position on the bill last time, and so a lot of things, I mean, there were things that certain criminal lawyers said there were parts that were unconstitutional and other issues, but at the end of the day, I think it's important before I get involved in any discussions and before any single health department gets too far committed to a particular position, that we at least have an understanding of what the health departments think about the different substantive parts of it, as far as like the needle exchange and the proposals that you all are more interested in than not, because I think the health departments will probably be asked at some point to testify as hopefully they kind of come together in an interim committee and address what they're going to do on this. So I don't know whether we want to take time this morning or whether you all want to send emails in to Randy as chair of the legislative committee or me, just reflecting the position of your health department. As I said, I know from conversations with KPHA, I talked a lot with people from Three Rivers and Northern Kentucky, and I think I saw a lot of emails where people from those two health departments were involved in the threads, and I know they're trying to resurrect this thing and make something happen, and I think we need to resurrect it smartly if we want something to happen, and not resurrect it kind of wildly and just kind of throw rocks everywhere and hope some of them hit something. So I just need to kind of know what y'all think. And Scott, it doesn't matter. I mean, I'm not going to be doing anything for several weeks, so it's just if people would rather shoot me a couple paragraphs of what their view is of how the needle exchange and the role of the health department in heroin problem in Kentucky, that would be great. And then I'll share it with Georgia, Randy, Allison, the legislative committee, and Scott, and we'll make our position known. I'll talk with the chairman of the respective committees that will be looking at it on an interim basis, and then I probably have a substance abuse meeting coming up sometime in the next month, and I'd kind of like to know what the health departments think before I go to that and meet with the executive director of that agency who comes to that committee meeting. There's a representative from PPH that comes, as well as a lot of other folks that have been appointed as the oversight under the legislation, and sort of the oversight for the bill. I'm not really sure what we do.
As we think about this issue, how many of us in our MAP assessments and our community assessments had substance abuse identified as a problem? So we have it identified as a community problem. Needle exchange programs are evidence-based and are shown to, reduce disease. And I know there's some, a lot of issues around needle exchange programs. Some people think they're great, and some people think you're enabling drug users. So, aside when we start looking at the pure science of it, though, it's going to be very important. Public health, we're at the table, and we voice our opinions, make this known. So I encourage each of you to go back, look at Senate Bill 5's language. If you can pull it up on the internet at the LRC, look at Senate Bill 5's language, and then do some research on needle exchange programs, and just look at that and think about this, and then we'll be better prepared for a more informed discussion and be proactive as we work with the bill's sponsors there, and try to make sure it's very language is something that we can live with and can be seen as a supporter of and stepping up to the plate.
Scott? Scott?
Doesn't matter, ladies first.
Okay, we got a comment in the room, and then we'll come to ITV.
Okay.
One, the Portsmouth, Ohio Health Department, Fayette County Health Department has a needle exchange program that I've been talking to, and, if I need to arrange any kind of visit with that health department to see how it works. But they've been doing it for 3 years now, and it significantly has cleaned up their department. They're not finding as many needles, and they don't have disease data yet, but at least the public health issue of kids stepping on needles in the park is not enough. And then my other comment is this might be an opportunity for we as khda, we as health departments, to do something for the legislature. This is something that they're really behind. This is kind of like what's in it for me, what's in it for them, where we can step up and actually do something for them instead of us asking them to do something.
Because they just funded our retirement increase completely, so this would be seen as a very much goodwill gesture, yeah. So let's go to ITV, and then we'll come back to Dr. Leach.
Scott, this is Lynn up in Northern Kentucky, and we have put together really it's a compilation of all the evidence and the research out there on needle exchanges, and put it in the form of talking points and some, in addition to that, some questions that are probably going to be the most commonly asked questions from the people that oppose needle exchange. And I will send that to you in just a couple minutes here that you can share with folks, because I think it helps put it into perspective. Up here, a couple of years ago, heroin and deaths from heroin overdoses wasn't on the top 10 list of causes of death for us in Northern Kentucky. And in 2 years' time, it's become number 8, and it's rising rapidly. We're seeing exponential increases in hepatitis C and now hepatitis B, and we know HIV won't be far behind. And, we don't have a lot of tools in our toolkit to stop this transmission because we've got so much IV drug use going on. And so, I really feel like this is something that my board has to seriously consider. But not only that, it's to do it right, you have to educate the community and not let the opponents get a foothold. And I think these talking points help in doing that. And so our community-based coalition is going to be speaking with one voice, using these talking points and talking to the stakeholders, the elected officials, and a lot of other folks to try to get everybody on board in the community, or at least the majority on board in the community, to see the benefits to the community, the benefits to law enforcement and other folks, and not getting stuck with dirty needles that we've got all over the place, and that sort of thing. So, and I guess I would encourage folks to look at the evidence, and we're kind of in the thick of it up here in Northern Kentucky, and if you have an opportunity to put things in place to prevent that from happening in your community. Heroin didn't take any of my time 2 years ago. It takes anywhere from 10 to 25% of my week now. And then I've got other staff who are heavily involved in it also. And so, we've had to divert resources to try to address what's going on. And it develops so quickly. And so I would encourage you from a prevention standpoint, for those of you who are in communities where it's not as big of a problem, this is the window of opportunity to prevent it from becoming a problem.
And if you don't think it's a problem in your community, you probably just don't realize it yet. In Clark County, I know we're in the same boat at a recent meeting with our coroner. It is the leading cause of accidental death in Winchester and Clark County right now. So it's northern Kentucky, it's central Kentucky, and it's permeating all, as House Bill 1 with the prescription bill there dealing with OxyContin and the prescription drugs has proven very effective. They've now moved on to heroin, and we're seeing that resurgence again, and it is very common. Talked with our police chief here just a couple weeks ago on this issue, and it's permeated central Kentucky, I know. So, Rice.
I guess my request is, as CADA figures out what it thinks, it really on this one needs to keep in mind that one size does not fit all. Our Board of Health, as I've mentioned a few times, is very different from most of yours because ours is more than half of it is not a health provider of any kind. And those folks have realized that things are changing on the ground a whole lot faster than the state health department or the General Assembly are capable of keeping up with, not to mention the United States Congress and the Federal Department of Health and Human Services. So Lexington and I suspect northern Kentucky and a lot of other places aren't going to stand around and wait on anything. Specifically heroin, 3 months ago it came up in a Board of Health meeting and I tried to sidetrack it just so we could get our act together before anything happened. Well, it didn't work that way. Our chairman invited Mayor Graves, Commissioner of Public Safety, to our board meeting next month to talk about heroin. So, my God, we done caught up on heroin. Just keep it, and then that's fact two. 3 years ago, in the discussions of what we ought to have in a community health improvement plan, the community, and I'm not talking about just the social service agencies, I'm talking about the business community as well, put one of the three main issues as safe neighborhoods, which runs right into this thing. So whatever we do as CADA, give me some room to maneuver, because if CADA for some reason excludes the opportunity for those of us that are behaving somewhat differently to have room to operate, it gets hard to stay a member.
And
it's not very hard to give room to maneuver.
And I think you see that, very, very cognizant of that in CADA and everything we do. It's making sure health departments, all health departments always have the options of doing whatever that they need to do to address their community because we're all charged with that. And CADA will not take a position contrary to a health department doing what meeting their community's needs. But I think, as us as an aggregate, because most of us are moving forward on the heroin issue, and we've been dealing with it. I know in my community and our community health improvement plans has involved heroin for some time now. So, yeah, a lot of us are moving forward. So appreciate you sharing that, Lynn, and we'll get that out to everybody so we can have a much more informed discussion about it, and then we can start deciding what our strategy is going to be to be very proactive on this. So thank you, Steve.
Yeah, I would note that remember it's on the governor's list of the initiatives for the
Kentucky Health Now.
Kentucky Health Now. So I can't believe that something's not going to be going on from the executive branch, and I just feel like when we're asked the question, we're asked to testify, we as a group of health departments need to kind of have some positions about the various things that impact us in it. Anybody have anything else? Thank you.
Thank you. Just real quick here before we get on to our first presenter today, executive committee report. We'll be talking about the main thing we've been focusing on, strategic planning, here a little bit later on. Georgia will head that up for us. Just want to mention that we have been contacted by the folks with the summer feeding program that we did last summer, wanting to know if we are wanting to participate again. So if you have any strong feelings one way or the other about your involvement with the summer feeding program, or we inspected the sites where they did the summer feeding, please send out those emails to Mark. He's graciously volunteered to head that up for us again, and let him know, and we can kind of compile that and see, because I know, we thought it was going. Some of us thought it was going to be a pretty big much bigger deal than it turned out to be last year, and we don't know if it's, the goodwill. There's lots of things to be weighed out here about whether we participate again. So any comments to Mark on that? Bylaws, our bylaws committee has worked on some revisions. We're going to be sending those out and to have discussion at the May meeting. And so just to be looking for those. So when those revisions come out, just giving you a heads up now. So be looking over those and getting your comments ready for that. And then Smoke-Free Kentucky, I do want to just talk about. I've had several directors talk to me about the most recent media release from Smoke-Free Kentucky, the Thanks for Nothing release that was sent out. I've heard a lot of negative feedback about that, and Steve and I were both at the meeting and encouraged that release not to take a negative approach. We encouraged Smoke-Free not to be negative, and the lobbyists with Smoke-Free kind of overruled that. So again, we're as part of Smoke-Free Kentucky, we're going to be advocating, but we tried to make it very clear to Smoke-Free Kentucky that health departments, CADA, we are not a single issue entity, and we cannot die on the cross, so to speak, for any one issue, because we're too engaged and too involved in many other things. So I was point blank very honest with that. I said if you continue to take a negative approach, I feel like our membership is going to want us to distance ourselves from that coalition. So, and I think it's contrary to what we're trying to accomplish. So, I have great respect for a lot of people in Smoke-Free Kentucky, but again, I think sometimes frustration, you try to go negative, and I just don't, I don't think, but the hired media consultants say this works. This has been very effective in other states that they have done this with a campaign such as this. So, we shall see, but I think those of us in health departments, we have too much to lose. I'm never going to tell my legislator thanks for nothing. So, act accordingly and just realize that was not with the blessing of your representatives on that coalition, and we'll keep you informed. Okay. Everything else is going to be covered the rest of the meeting here. So right now, Ms. Shelley Adams, and we're going to talk to us about our Title V needs assessment. So, Shelley, up here at the podium, and do you have a PowerPoint?
But I have some handouts, and I'll also be sending this out to the health departments. Thank you all for giving me some time today. I'm Shelley Adams. I'm the Title V Administrator of the block grant for the state, and I work in MCH. I am the branch manager of Child and Family Health Improvement. And what I want to talk to you briefly about today is the Title V needs assessment. It is that time again. How many of you were around in 2009, 2010 when we did the last 5-year needs assessment? So some of you know what's going on with that. We are going to be working very closely with you. We are going to be using some of the information you collected from your community needs assessments that you did, and we will be getting back in touch with you to let you know all the findings from our statewide needs assessment. Right now, I am asking for your input and your cooperation to perform a patient survey again as we did before. And this will be a very simple front and back survey that I will be sending to the health departments. I would like some volunteers to let me know by Friday, and I realize this is short notice, but I would like to know by Friday who would be willing to participate in this survey. I will be sending the algorithm that I'm passing out today to those of you who are on ITV.
A really dumb question. What's Title V?
I'm sorry, it's the Maternal Child Health Block Grant.
Thank you.
Sorry. Title V, yep. So I'm going to be asking for your health department to volunteer to disseminate these surveys and get those results back to us. We are currently looking at the first full week in May to do this. I realize that's short notice. If that's going to be a huge problem for any of you and you do want to participate, please let me know. Like I said, I will be sending an email to all of you so that you can respond to me. I also have some cards here if you would like to contact me before I get the email out. I'm going to try to do that today. So I'll just leave these here with Scott. But this algorithm just basically explains this is going to be a very simple procedure. I'm going to email the surveys to you. If you want to participate, I just need you to print them off. I need you to identify a single contact in your health department and let me know who that person is. I am the contact on the DPH end. I want you in your health department to choose 3 days of that week where you have the highest flow in your clinics of patients. And just let me know all of this information. Your contact is going to print off the surveys, provide that to every patient that comes through and signs into those clinics, have them return it back to that person, and then at the end of the week, collect them all and just mail them to me. It's just very basic. The survey, again, is going to be 1 page front and back. We have tried to make it at a very low reading level. And if you have any concerns or questions about it, I'm the one you should contact. Let me see if there's anything else. That's basically it. We're not asking you to print them off in colored paper this time. It doesn't need to be colored. It's going to be black and white. Also, on the bottom of the survey, I'm going to put in the footer an identifier for your health department. So when you let me know by Friday that you want to participate, I will prepare surveys specifically for your health department, same survey. However, I will put in the footer an identifier for your specific health department so we won't get them confused when they come back. I realize that this is more work for your staff, but hopefully it will not be a grueling task, just something very simple. And do know that this is really good information for you to collect. I want to thank you all so much for the last round we did in 2010 because that was invaluable information. The federal folks were thrilled that we got such a huge response from patients across the state of Kentucky. We had, I think it was close to 3,000 responses from patients, and that's unheard of. A lot of states couldn't even touch that. You all did an excellent job with it. So I really look forward to partnering with you. Yes, Maria?
I just have a question. When we did this before, the complaints we received from the patients was that it was too long.
Okay.
So I just wanted to share that with you. They complained that it was as long as it was. I don't know how this year's will compare to before. I didn't think it was unreasonable.
Yeah. Well, you know.
They did.
We do have an optional question on here this time. You all are acutely aware, I'm sure, of the infant mortality issue in Kentucky and across the nation, actually. So we have added a safe sleep question. If they want to answer it, fine. It may not apply. And it does state on the survey, and I apologize, I was going to bring it, but then I thought not to. We're just asking for those who do have infants under the age of 1 if they would complete this question. It's a real basic checkbox. A lot of the questions are checkbox. So it should take just a minute to go through it. Any other questions? Concerns? Input?
If we, at our local health department, I know lots of times in doing surveys, you know, an incentive, if we give everybody a ticket and their name goes in for a drawing for something that we provide, not asking you all, that's not contrary to any of your rules or anything with that to help.
That's up to you.
Help them get a more flavor, be more positive in taking the survey, right?
That's up to you.
Okay.
Yeah. Yes?
Can the 505 coordinator be the contact person?
Whoever you want. I was going to suggest that, and then I thought, no, I'm going to leave that up to you all. It's for you to manage, so it's your choice.
Somebody else, and they can't charge to codify, not the coordinator?
We can certainly talk about that. I don't see that there would be a problem with it. Just let me know.
There's only the coordinator can charge to codify.
Well, and actually, someone who works with the coordinator could, but for this purpose, let me me find out more, and when I send the email out, I will include that in the email. But I really don't see that there's a problem with it. I don't see it as being very time consuming, but then again, it might be. I don't know. I don't know what happened last time, how easily it went in your health departments last time. Did you have a question, Jim?
Yes. Any chance this can be done on Survey Monkey?
Actually, we wanted to keep it as simple as possible. We talked about that. We talked about using tablets. We talked about a number of things. We want to keep it very simple. And for ease of use by the patients, we really want to just keep it on paper. We've been discussing this for quite some time, but yeah. Eventually maybe, but not right now. Any other questions or comments? I really appreciate your time. I will be getting an email out. Like I said, my goal is by close of business today. And I do need to hear back from you all as soon as possible. Remember, it will be the first full week in May, so the week of May 5th. And I welcome your continued feedback on that. Feel free to contact me. Thank you very much.
Okay, thank you, Shelley. We
You're
appreciate it. Okay, Miss Georgia with our strategic planning update.
I need to get hooked up here for a second. Good morning. Is there anybody in here that wasn't at the planning meeting at CADA, at the retreat, the conference? Okay. Okay, well, we assigned you all to a lot of stuff while you weren't there, while you weren't looking.
I know what the problem with infant mortality is today that's different from 5 years ago? No, I'll never know that. Making an ass out of myself once is enough. I want to do it twice. She said, as you know, there's a problem with infant mortality here in Kentucky and otherwise, the changing problem. I don't know what it might be, other than drug abuse.
Okay, so I sent you an email a little bit earlier. There should be 2 documents. This PowerPoint, I hope everybody's getting really used to this format because I'm sending it out, adapting it a whole lot. But you've got a Word document too, and the Word document has all of our committees on it and names assigned to the committees. Now there are 6 people that I'm unsure of that are not, their name is not up there, but I'll need you to get in touch with me wherever you are if you don't want to be up there, because I'll be trying to place your name on there. If you have a problem with where you are, or if you want to be on more committees or anything of that nature, please get a hold of me. You can call me, you can email me, and we'll have a discussion about it. So this is where we started. This is where we went with each of our committees. We have committees with leaders. The leaders are not really to boss everybody around. They're to make sure you have everything you need and be your report out to the group person if you want them to be. The work group chair people are the ones who are really going to be the workhorses driving this thing, because they'll be recruiting maybe other members than who they've already been assigned, and they'll be coming up with what is it we're actually going to do, what kind of deliverables that we're going to have. So under each of the deliverables, we'll need to have by next time some SMART goals, an aim statement,
So if you need to refresh on what that is, we'll talk about that in a minute. The committee chairs need to come together with your group, talk about your plan, how you are going to work together. Are you going to have phone calls? Are you going to meet at CADA? I'm hoping we can have time during this meeting every month when we're all kind of here that we can, our groups can meet together and we can report on that. So the SMART goals, I know some of you are probably more familiar with this than others, but all of you have heard about it at some form or fashion. But this is what we are going to need for your projects. Whatever you're going to do, we have to know what that is, and it has to address the issue. You have to be able to measure it some way. And I put attainable, I think. There's a lot, these things are a little bit, different ones that you look up say different words. But let's not do things that are attainable. Let's do things that are ambitious. And let's make sure it's realistic, though, and we need to put a time frame on it in addition to who's going to actually be doing it. All right, so your little work groups that you have, and you got that on your Word document, you can have additional members if you want. You can recruit them from anywhere you want them to be. They can be people. They don't have to be directors. They don't have to be members of CADA. They can work for you. They can work for other health departments. They can work for the state or anybody else you think that you need their knowledge to help you. Okay, so here's what we're doing. We had much debate about whether or not to try to formulate this as a strategic planning committee and hand it to the work group. Says, here's your project, do it. In the end, we decided we would give you the raw data, think way back to the sticky note day. So each of these items was a sticky note that day on a fish. So the committee will take a look at these. From those, determine how to address those. What is the project? What are we going to be doing? So next time, the report, either from Dennis or Deb, for this particular one, we'll talk about your projects as a work group. What are you going to do? What do these raw pieces of data mean to you in terms of how we need to move forward as CADA? This one and another one that belongs to Roanya have spots where the heroin stuff could easily be put in place. There will be times when there's overlap. When there's overlap, reach out to the other committee. The last thing in this world, or to me, and I'll get you in touch with the other committee, the last thing we want to do is have people in different spots working on the same thing and not knowing it. So we want to put all our efforts together and move forward together. So I feel like that the health status work groups, they're part of the same committee. They're going to be working on very similar things, so they'll probably have a lot of time that they need to talk together. All right, so this is Dennis. Dennis also has, let's see, on his group, Gigi Meredith, Lynette Renner, Mark Pyle, Paula Thornberry. So you are on a work group. Somebody will be getting in touch with you. If you don't want to be on that work group, or you want to be on more work groups, get a hold of me, let me know, and I'll assign you more. Okay, so this is the other one that the heroin might fit into. So this is Roanya's work group. On this we have Thursa, Raphael, Sherry, Irwin. That's somebody that at KPHA got recruited to be a member of that committee. We have LaQuandra, Rice. He's on, that'll be good, Rice. You can make sure that heroin work group in Lexington doesn't get you in trouble. Debbie Miller, Judy Mattingly. All right, so, the foundational package of services, this one is myself, Allison Crystal, Kathy Crown Weber, Sarah Jo Best, Allison Bashir, Marcia Hodge, and also Ross Leach.
I was recruited for that.
Yes, you were drafted.
Minding my own business.
Drafted. Okay, so organizational culture and communication, that's Drew, Allison Bashir, Allison Adams, Andrea Renfro, Pete Shepard, Rebecca Keith. Then benefits, we have Mark Hensley, and let's see, leading that group. And he has Scott Lockhart, Gail Tempero, Susan Lappert, and Teresa Hunter.
Ursa. This one was in huge demand. Renee Blair, Nancy Crew, Denise Beach, Teresa Hunter, Kent Costner, Steve Bing, Ron Horseman. MCO contracts, Jan. She has Sean Crabtree, Donnie Fitzpatrick, Bobby Ratliff, Randy Gooch, and Tony Cox. Then funding methodology, Melissa Royce. She has Scott Lockhart, Ken Pfizer, Sheila Sharp, Kent Costner, Jill Ford, Bobby Ratliff, and how's that last? I don't know this. Greg
Brewer.
Greg Brewer. Okay. I think that might be it. And then Lynn Sadler, Highland Insurance. I think that might be on. Yeah. Okay. So on the private insurance, this one was also quite in demand. Nancy Crew, Lynette Renner, Thursa Sloan, Brent Blevins, Jill Ford, Judy Mattingly, and Maria Hardy. All right. So your assignment from here is to get in touch with your group, wherever your name was. If your name is not up there, get in touch with me, or I'll get in touch with you, and we'll find you a home or something you're interested in. But you need to work with your group. You need to meet one time at least between now and the May CADA meeting. You'll need to develop your projects based on your raw data. What are you going to be doing? What's your deliverable? How are you going to attack that? And then an aim statement. Your aim statement will be based on SMART goals, which just means you got to give it a way to measure it. You got to give it a time frame, and who's going to be responsible for it. And then somebody will report that back at the next CADA meeting. So you've got 3 committee chairs. You can have them do it for everybody, or the work group committee. A member of it, either chair or somebody else, whoever wants to be the report person can do that. We're not picky about that. Whoever has the passion and the expertise. All right, questions? Clear. Everybody knows exactly what they're going to do, apparently. All right. Yes.
Do you want a written aim statement? I mean, I know we want it written, but do you want it, disseminated to the group, or just?
Yes.
Do you want that emailed?
I would like that emailed to me, because I will be building that document, that spreadsheet that we started with early on, that had our 3 big goals, which are health status, our statutory obligations, and our funding. Those 3 things. I've got a spreadsheet started that has our different strategies under there and how we're going to accomplish them by what date and all that. So with your data, I'll be filling up that spreadsheet. So if you email it to me the morning of CADA or the night before, that'll be fine. But we do need a report.
Can we ask someone from KDPH to be on our committee?
You can ask the president if you want to. Whoever you can get to help you that can make something happen, that's who you want. So.
Yeah, even we talked about it, our KPHA, whatever hotel room we were in. Even the private partners out there, anybody that we can garner support to help us move our work group, so it doesn't have to be a public health employee. It could be a private person or private employer.
If you have any questions at all, please email me, give me a call, and we'll work through it, whatever it is. So I do have Kathy Neal. I'm going to be talking to you. Stephen Ward, Karen Cooper, Scott Shrewsbury, and then there's Oz back there too. I'll have you 2 in person so I can have a spot for you. But the rest of you can expect a call from me. So. All right. Thank you very much. I'm really excited. This is going to take us where we need to go. So, all right.
Thank you, Georgia. I think, again, that this is a great opportunity here. I hear all the time about, we want CADA to be responsive. And what's CADA's position? This is the opportunity for everybody to voice their opinion, to have input on what CADA what we're doing with CADA and health departments and public health in general. So please take advantage of this opportunity because it's very important that we all have our say. We all can help to mold the direction that we're taking as a group. And now more than ever, if we do not determine our own direction, others will determine it for us. So if we do not want to be out in the forefront and be proactive and be advocating about where public health is headed in this Commonwealth, others will dictate that where we're going. So, and I don't know about you all, but I don't like being told where to go. I've been told that enough here lately. Let's make our own path, okay? So I appreciate everyone's involvement with this. And thank you, Georgia, for heading it up. She's the chief cat herder. And so it's a big undertaking here. We have other people who are already interested in this, thanks to Jen Harris and some others there. I know Dr. Wyatt from the University of Kentucky, Dean at the UK College of Public Health. He's going to meet with the executive committee in May to talk about strategic planning. So we already have some people, in the University of Louisville, some different ones are really taking interest in this, and they feel like that we're really on the right track. Instead of being reactive to budget every year, we need to make the case for what we can do for the Commonwealth and what we need to do that with. So again, appreciate everyone's involvement with this. Dr. Leach.
I attended a meeting Saturday in Lexington sponsored by the Kentucky Medical Association. They had 25 physicians from around the state, some from as far away as Clay County. And the purpose of the meeting was to engage practicing physicians in public health. There's only one public health guy there, and that's because I've volunteered to go. But the point I want to make is the leadership of medicine in this state has realized that they can't prevail alone the way they were able to do for 40 or 50 years. And they are reaching out and training people. So what's the point of what I'm saying? Find out from the members, the physician members of your boards of health, if any of them are paying any attention to this, because the Lexington Medical Society, for example, is really breaking with its tradition of sort of the members only to physicians, whoever you are. It's going to take a year or two or three to get there. But that medical society has realized that this is bigger than just those that pay dues. It's coming, and just like you're saying, let's get in on the ground floor and help design it. If you have physicians anywhere in your system that seem to dig what we're about, bring them in, whether they're on your board or not. Because what I'm getting at is these different groups are going to go back and ask their members and their players, are you involved, or is anybody talking to you? And at a minimum, we ought to be able to have doctors say, yeah, well, my board of health, my health department person has been talking some to us about this.
Very good. Any other comments? Okay. I know now we've got a time on the agenda for open discussion. I know directors, I've heard a lot of feedback that they wanted more time for open discussion here, and we have able to accommodate that on the agenda today for pressing issues. And I know DPH will talk to us. I'm sure all of us are concerned about allocations. Dr. Bayfield, Commissioner Bayfield said last week in the next 2 to 3 weeks we would have allocations. And so I'm sure they'll update us when DPH gets here. But besides that, any other issues that we'd like to address? Randy?
Do you have any more information on actually registering the local health department for the SPGE?
Okay. For those of you who were not at KPHA, we had conversations last week. There was a presentation with House Bill 1 last year that involved the special purpose government entities, our public health taxing districts. We worked very closely with Auditor Adam Edlin and his staff in the formation of that bill, and the intent that we supported there, because this issue was brought up when the bill was before the legislature and was vetted, was that we would not, that there was first a question about does the public health taxing district have to register, and does the health department have to register? Are there dual fees? What will this look like? So for a single county, are you having to register both your taxing district and your health department, and are you having to pay a fee for both? Well, our position was it was not fair to pay a fee for both because it was the same taxing district money, so it was in essence we were being double taxed, double fees on the same taxing district funds. In a district, you would have paid a fee for every taxing district, so if you had 3 counties in your district, you'd pay 3 taxing district fees and then 1 fee for your district health department. That was never their intent. At this presentation, one of the attorneys for the Department of Local Government, in their implementation, as they're looking at implementing the bill now, said yes, we have to register both, and initially they were saying yes, we were going to have to charge fees on both. We had conversations with Tom Bennett with the auditor's office last week, and then they communicated with DLG, then I communicated with Russ Salzman and Steve. All of us were back and forth there, communicating quite heavily on this. So this, we will be getting more guidance in writing, but this was what was, when we left it last Thursday with DLG, the intent was there to saying that, yes, we would have to register our public health taxing district, our health department, register the district and pay a fee on the public health taxing district. We would have to register our health department, but there would be no fee associated with it. So because the health department is receiving our taxing district fees, there may actually be more information that they're wanting there from the health department. And I know Randy, they'd worked on a crosswalk from our BUD form to glean the information that we would need to provide them, so that potential is still there, but there will not be the dual fee. Okay? So the web page there providing this information, for those of you that have not done it yet, your UFR is due May 1st. So if you haven't done your UFR yet, you got the rest of this week and next week to do your UFR. And that, so this is designed to, do away with that. The UFR would no longer be required after this year. So again, I understand them wanting us to report some on our health departments, but no, the issue of the dual fee was the biggest concern there. So again, nothing has been finalized, but this is their intent, and they've had this conversation. They're talking back and forth, the auditor's office, DLG, to throw a curveball at them. They're at a loss right now about, I think, the district health departments. I know, Dennis Cheney, you've got some of them that you've got a county that doesn't have a public health taxing district. And like Rice Leach, no one's ever known what to do with Rice in the state since he got here. So what do you do?
Appoint him to planning committees.
Fayette County, if you've got a urban county government, who do you actually register there? Because, the Fayette urban county government is funding the health department. So,
Actually, it is not.
Okay.
The taxing district is funding the health department.
Okay, good deal then. So that because they were going to get in touch and find out more information. I put them in touch with Department of Public Health, with Administration and Financial Management, and to provide them all the information that they were needing there, and then they'll be doing DLG, maybe in touch with directors if there are questions about their health department and exact, formation of that there. So that's kind of the status right now, and so it's just kind of it's in progress right now. We'll go to Allison, then back to Randy.
I'm not familiar other than when I have my passcode and my register, my username, but my health department doesn't have one of those. Is there a way to go in and register without having that, or do we call the DLG to, because they, what I'm talking about?
Because they sent us out all that information for our taxing district, but again, we haven't been sent. And so I think, they told at the presentation, if you haven't registered and you're supposed to register, they're going to contact you and whatever. So I think at this time, the intent is we'll register our health departments, but I think for both of us, we'll just kind of wait till we hear from Russ, and I'll touch base again with Russ at DLG and seek guidance on how they want us to proceed right now, because, and they know, DLG knows we all want to be compliant. It's not we're resisting or whatever. We're just figuring out how to be compliant. So number one, if you do have a taxing district, make sure it's already been registered. And as long as you've done that, you've shown good faith. And then when we get more guidance, we'll proceed. They'll provide us the information and see about if we do have to register our health department and how that proceeds and what that looks like.
And the fee is due by July the 15th.
By July 15 is the fee, yeah.
And I will say, Scott, you know, when all this came about last year, it was our understanding initially how it was written that we would have to register both, but pay one fee. But then we got conflicting guidance from DLG, you know, because they were saying that no local health departments were not special purpose government entities because, you know, we were under the purview of the Department for Public Health and the state. But now I think, you know, Darren Sammons, he's the attorney, as he's reading this law, he was kind of new on the scene when we started having these conversations. And as he's been reading through it, he feels like that's in our best interest. That's why we worked on that crosswalk last year. That crosswalk will have to be updated to make sure that it can tie into our budget, where it will actually provide the information that every local health department would need to put that into the electronic system for DLG. That way it'll be the same for everybody. We won't be determining ourselves what line items that those actually go to.
And FYI, Glenn Oldham has retired from Department of Local Government. I know a lot of us have been used to working with Glenn on our UFERS and our taxing district budgets and all that stuff. Matt Froelich has taken his place. So again, with all these changes and stuff, I'm sure Glenn had in his time and figured it was a good time to go and let the new blood deal with all this new system and all that stuff. So.
What was the last name again?
Froelich, F-R-O-L-I-C-H. Yeah, because he was at KPHA last week. He actually started yesterday, was his first day on the job in that new role. So he really got baptism in fire last week at KPHA without even having to assume the duties officially yet. But he was brave enough to attend the session with their attorney, with Darren. So, okay. Any other questions on House Bill 1 or the SBGEs? We'll get out information as soon as I get any more from Russ Salzman and DLG. We'll forward it. Okay. Other issues? Anything from ITV for open discussion?
This is Kent.
Hi, yeah, Kent.
Scott, we've had a conversation about this, but still, I have no information on where we stand with, oh goodness, one of the MCO's, Kentucky Spirit, as far as the remaining amounts due to the health departments. Have you heard anything else about that?
I have heard nothing else about that. We can ask the attorney here, Allison, with DPH, if they've had any contact on that, but I have not heard anything else about getting any more from Kentucky Spirit, no. So I don't know any updates on that, yeah.
Do you know if is there any representation, health director representation on the committee that's entering contracts, making contracts with MCOs?
We have talked about it, but no, there's not. You know, Ron Horstman and AFM is heading up. The question there, ITV there about, the MCO contracts. We've, had conversations, but there's not a public health, there's not a CADA rep, there's not a public health director on the committee that's actually in contract negotiation, no. I think, the suggestion was been made, and then again, it's, I know Ron has been heading that up, and he's been working a lot with the MCOs and stuff, and it's just so, it is a very consuming process there, because that's pretty much what he's been, so, we can talk about that when DPH gets here, about, what the status is of those contracts and our input, because I know, cost settlement language for home health, is that still in there? That's very important to a lot of the health departments. And then, the shall pay, that one word there for the preventive package is very important to all of us. So, making sure that as these contracts are renegotiated, there's those things, I've been reassured that they're advocating on our behalf, but it's a valid question that we need to put forth when DPH is with us, so.
I guess it's just, to me, if you're dependent on some of the MCO revenue, if we're gonna start the budget making process, if we can't be assured that at least status quo is there for us to begin budgeting, or or not, it makes a big difference.
Yep.
Scott, I worry a lot about the ability of the public health system in Kentucky to carry out its statutory mandates. And I hear very little discussion about that. But at the end of the day, that's the thing we do best. That's the thing that's our market niche. And the reason I'm thinking about it right now is our department is getting ready to have a discussion with the state about how we plan to assure in Lexington that communicable disease and regulatory and epi and public health education and preparedness get dealt with, and the impact that's going to have on these programs that we have been told to do because it comes from money that's appropriated in the budget. But that money that's appropriated in the budget is not only declining, but it stays steady. It still buys less than it would have. And I just think it's, whatever we do going forward, guys, if somebody takes away epi and communicable disease and regulatory, we got nothing. Nothing. No reason to exist.
Yeah, I think
and
that.
we don't talk about that at any level. Federal
we're
down.
getting ready to talk about it because that's part of the foundational capabilities and the statutory requirements. We have to, as a group, decide this is what we're going to do and give us the money to do
I
it.
understand that, but if you listen to the discussion in public health operations in Kentucky, the guy that raises it most is named Leach. And I just think that's a problem in the long run.
I think that's why you got drafted for that work group, for sure.
I thought it was my good looks and my
but that's, that is a discussion, to be had. We had, the panel discussion that evening there at KPHA with, the changing this generation unbridled health. I mean, and I was freely admitted there in that panel discussion, I didn't even remember about unbridled health. There have been so many catch lines there, it just kind of slipped my mind, for a while here. But, the conversations we have moving forward about not just can we get paid to do it, but should we do it, what should we be doing, and what, instead of the tail wagging the dog, here's the money, do this program, should we be saying this is what we need to be doing, we need the money to do this. And so kind of taking a whole different approach here as we do business. Yeah, Maria.
I was just going to say, I think we are moving further along and accomplished more since we started the strategic planning and organizing ourselves as a group with some, hopefully down the road, with a little bit of power. Because at least we're going to have this to fall back on and to say, this is what our group, and it's going to be not just directors, but we're going to involve other individuals. I mean, I think now we're setting a foundation that we can build on. Before, everything was so fragmented. But now we're getting it together, at least I feel like we are. And I think, like Georgia said, this is going to help us with those mandated services, and help us set our priorities at each of our health departments. We're all different in many respects, but we're all the same. So we have to work within our own communities to figure out how to put all these things in play. So, I mean, I feel really, I'm encouraged, and I think it's a very positive thing that we're doing.
And I think that, being 61 health departments across the state, we're not going to agree on every issue all the time. We know that. So, but there's still, we have much more in common than we do apart. And by combining our resources, we magnify that strength. And so, again, I commend everyone for their involvement, and that's why we're reaching out to everyone. Please be involved. Please be engaged, because in the General Assembly and the legislature this time, I never remember local health departments being center stage as much as we were in the halls of Frankfort, with legislators talking to us and things. And, Bob Leeper, that PVA fee deal, people, you all give yourself a pat on the back right now. We mobilized. We all had a common concern there. And Bob Leeper said his phone had rung off the hook. He'd heard more about that than practically any other issue this session whenever I testified before his committee that day. So, great. That's the way they need to know. Our legislators should know us well, and they need to hear from us, again, not just when we want something, but it's just like this needle exchange program. This is an opportunity for us to step up to the plate and say, here's how we can help you. Here's how we can do, so we can use this very much to our advantage. How public health is really a benefit to them and an indispensable part of what they need for public health protection and safety. Allison?
If you remember, probably 5 months ago, I asked the question about our MOA, our Memorandum of Agreement, whether we could choose to do or not to do that program based on our community health assessments. And I think that that's another question that we're really going to have to raise and, to stick together. And it gives every health department the autonomy, whether, you want to do it or you don't want to do it. But we have to be a united voice to say we should have the option to do that in our community, because, if it's not a need in your community, we shouldn't be made to do something and yet make 100% of the rules apply to us for the 30% of the funding. And we should be able to, as a business leader in your, making those decisions and being accountable to our boards of health. It's not a good business model to take something that's a lost leader and doesn't affect your community's health. And we really have to figure out and review those MOAs and decide, what's workable in our community to assess that and be able to advocate that, preparedness is something, yes, we really want to do, and it shouldn't be an all or nothing MOA. But I was told at the direct question that, we couldn't choose. And so, that's, again, something we really need to figure out before this next budget cycle, whether or not we have to do something that's not statutorily required for us to do.
And that's a conversation there that, it's the rock in the pond and the ripple effect. What do we do? As DPH being our primary partner here, and us being partners and working with them, if a health department doesn't carry out a program in that community, DPH is still tasked. If they've got this grant for the whole state, of who do they find? So it's a new way of thinking for them as well, and something that they have to be looking at, and us working on this together about, because, again, I think for the first times here, we've been seeing health departments refusing funding. I think we saw it with colorectal screening funds. We've seen it with the health benefit exchange dollars, different things here. It's just like, well, it's better for us not to do this. So that's a great conversation for us to have in unison with DPH and how we all work together on this, yeah.
Maybe I shouldn't say it, but
It's your last meeting, Paula, right?
What Allison was just saying, that question, and you said you were told no. Well, I went up, I walked up, and I marked through and added some language, and it went through, I guess, we're getting money. But I wrote in that we are basing our programs on our health assessment and our own strategic plan. And I've also put in, as we'll do these, as funds are available to them. So.
And they didn't take it back.
I know, yeah.
I got it was accepted.
I know, and I realize after this is going out all over the state, there might be something else taking place.
Yeah. Melissa, last comment, then we're going to take a break.
Did you say anything about the passport and CO contract being signed? Because, we've received two different messages. First we were told, hold our pets, way back when, and then another one came out saying, the contract hasn't been signed, and any services that you provide before the contract signed, you will not be paid.
I do not know personally. I don't know if any of the rest of you have had any contact on that, so. Yeah, I don't think it's been signed. I don't know the status, so we need to ask that whenever DPH time, okay? Let's go ahead and take a break, and then we'll be back here. Okay, so take a break here, and we'll be back in 15 minutes. Okay, we're getting ready to start back here on ITV and in the room. Appreciate everybody. Our partners from DPH are here. So if everybody wants to find their spot, please, we appreciate. We have our Deputy Commissioner for Clinical Affairs, Ms. Dr. Connie White, who will be emceeing today for DPH, so appreciate you being here, Dr. White.
Thank you. Thank you. Good morning. I'm the Junior Deputy Commissioner. I like to give Dr. Humbaugh a hard time whenever there's something, we're in a meeting and it sounds really hard. I'll look at him and say, this is obviously a job for the Senior Deputy Commissioner because the Junior Deputy Commissioner, and I say that very respectfully because of his experience, and I learned a lot from Dr. Humbaugh. But he has actually taken some time off. Write it down. It never happens. We beat up on him to try to do that, as we want everybody to enjoy some time with family and just some time not doing anything. Dr. Mayfield is meeting with Secretary Haynes as we speak. So y'all get me, and I get to talk with y'all. So I'm excited to be here today. And I'm excited because the first thing that I get to do is pass out an award. I figure that's a good way to start the program. We have several awards that Dr. Mayfield was not able to give, and we thank Brandon for giving those. We were literally sitting with the secretary at the time that the awards, and I mean, you know, Dr. Mayfield, very professional, but she was very bummed that she couldn't be there for the award ceremony. She said, that's one of the funnest things well, I don't think she said the funnest. She didn't say that wrong, but she said it's one of the things I enjoy most is giving the awards out. So we've got 4, I believe, counties, but none of the health department directors are here today. So I do want to go ahead and give one of the awards that we have. And I don't know if y'all have already talked about this, but we did a special recognition award to Ms. Paula Alexander. As you all know, she will be leaving the Commonwealth to pursue, this is Dr. Mayfield, she is leaving the Commonwealth to pursue a personal interest. Is that not like the understatement of the century? And I have met her personal interest at church the other day, and he is delightful. However, she will be leaving behind a tremendous legacy for those that follow in her footsteps. She was instrumental in making sure that Franklin County is a smoke-free community, including the parks, and just Connie talk just because we love her. So we'd like to present Paula with a Commissioner Award. Okay. And we are excited to work Judy in shape. So, okay, let's go ahead and start with, I've got just random notes here. So, let's start with CHWs, community health workers. I just had a conversation with Dr. Rangel, and I wanted y'all to know, where is Maria? We met for 4.5 hours yesterday on community health workers. As many of you know, community health workers was mentioned in the ACA as an opportunity for us to help with improving the health of our clients. I hate saying that word. They're patients to me, but I know I'm supposed to say clients. But right now there's no reimbursement mechanism. Community health workers are used throughout Kentucky. They're all doing different kinds of things, and none of it is reimbursable. So we pulled a task force together that I've mentioned before, where we are trying to come up with a system where we have a list of competencies of what a community health worker is, a curriculum that we can say, yes, if you're trained in these areas, then we're going to come up with some type of a certification, a loose certification for those folks, so then we can go to Medicaid and write a state plan amendment saying we would like to be able to reimburse these folks for their services. Once that's accepted by Medicaid, they then send it to CMS in Washington. Since it does have community health worker in it, that's definitely a good buzzword. And as you know, when you send stuff up the chain that's a buzzword, you're going to be more likely to get some response to that. So we'll hopefully we'll keep you posted where we are on that timeline, because it's going to take us a while to get all of that together. But we're looking to see community health workers as a sustainable
model that you can use in your offices. And as I told Dr. Rangel, I mean, I can tell the patient, you're a diabetic, don't drink sodas, but the community health worker can go to the house and open the refrigerator and say, Mary Lou, you got 2 liters of Pepsi in there. You know you can't be doing that. Let's go over this again. I mean, it's something that you've got a trusted peer in your community that can talk with you about what you need to do for chronic disease. So we're working very hard with that group. We're making some headway. We're meeting every 2 weeks. The group expands every meeting. We had to go to the conference room C this last time because as we talk about it, more people are saying, can I be in on this group as well? So this is not a closed group. Anybody that wants to participate, please let us know because we want to make sure that the people that are going to be billing have some competencies that they can show, and how do we recertify them, and how do we do CME on them. Other states are doing this. We're taking those models. We're tweaking it for what we think will work in Kentucky. So just wanted to know that that's something, and that was in your driver's manual. Speaking of your driver's manual, that was a good segue for, probably many of you haven't looked at your email, but about 10:30 last night, you got an email from me, and in that email was a note that said that we are trying to get our arms at DPH around what kinds of new projects people are starting up. We want to know if there are several of you trying to do the same thing. Is there a way that we can focus our attention to help you? One of the community health workers, we're hoping that will be helpful for some of you. So we've got a list of about 10 questions. I emailed the questions out. Didn't want you to have to do another survey. But those are some questions, and we're going to have somebody from DPH will be calling. We would love, if it's possible, to have a conversation with you and your head nurse and your budget person to just go over those questions. And most of them are yes and no. Some of them are if you're not doing, are you doing something that's not on the list? But we'd like to try to see what kinds of things are y'all thinking about doing that will help us know how we can help you going forward. So look at that email list. We'll be calling and see if we want to do this as quickly as we can. We'd like to do it this week if at all possible, so we can try to hone our efforts into helping you as you're moving forward. Before somebody asks me about the budget, I'll just say we don't have it yet. That's one of the things Dr. Mayfield is working on. There's lots of moving parts. We're doing everything we can to squeeze every dime that we can get out of what we got from the legislature. It's not what was in the governor's State of the Commonwealth address, unfortunately. And so that's something that when we're hoping to have by 1st of May, and I know you're trying to build your budgets, but we're hoping by the 1st of May that we will have beat this horse and gotten everything out of it that we can. So as soon as we know something, we will send that out to you immediately. Let's go ahead, and if nobody has any questions about what I've just gone over, we'll start going through people at DPH. Questions? Yes, ma'am.
I don't know if it's a question or a comment, but I think the questions that you sent out last night the answers to those could drastically change after May 1st. And I think that when that budget comes out, it's probably going to change the operations of a lot of health departments.
And the question for the people on ITV was, the questions that I sent out last night may change dramatically depending on what the budget tells you. And so we're certainly aware of that. So that, I think you're right. I think every answer to any of those questions would be prefaced by how much funding we get. And we got that. We understand that. Any other questions, comments? Thanks, Jordan. Okay. Marvin, do you have anything from MCH to report?
Yes, I do.
Okay.
There, hello over here. I wanted to make just a couple more comments in regard to the MCH needs assessment when Shelley was here this morning. One other purpose that may serve, we don't know for sure yet, is that also might be information that would be helpful to us in the state whenever it decides that it is going to submit for public health accreditation under the new standards 1.5. You may be aware that there was public health accreditation 1.0, and the department made the decision not to submit under 1.0. Yesterday, we had a very lengthy conversation, really focused just almost exclusively around 1.5 and how that differed from 1.0. I'm not the public health accreditation expert, but in kind of my terms here, the standards for 1.5 are much more stringent than 1.0. And where I'm leading to is in some of the domains, there's a strengthened emphasis on two-way communication. So one of the ways that the MCH block grant might be able to help is that needs assessment that Shelley was talking with you about truly is communication and priorities that start with the local citizens who use the services. Because we went on to say that, you know, it's nice to partner with different groups, whether it be CADA, the Friedel Committee, or whoever, but when you're looking at FAB now, what they're really focusing on are targeted populations, to the point actually that they would like to have your input first, the state hear the input, the state in essence develop draft strategies that go back to the recipients ultimately of those strategies, back to the state then for finalization of some of its strategies. So is there anybody else who wants to touch on accreditation or correct anything I said? Okay. That's pretty much what I had to say. Y'all have any questions for me?
Okay, let's ask Gary Kopczynski to come up. He's got some announcement from PQI. Just so that you know, Gary has been promoted, I guess you say, from assistant director. He's now the director of PQI. I've passed that on to Gary. So Gary is leading that group, and just wanted to, and he's very involved in accreditation as well, but wanted him to talk to you about the diabetes money.
As many of you are probably aware, House Bill 235 had a line item in it for $2.6 million for base service, continuation-based services in local health departments. Division Prevention Quality Improvement has a diabetes program, and I met with Teresa Wren this morning about the program. At the present time, we're looking at two different options. One is whether we're going to allocate funds or whether we're going to do an RFP, understanding that everybody's going to be looking at us from across the Commonwealth as what's going to be done with those funds. So here in the very near future, you'll be getting some further information about the diabetes funds, but I just want to give you a heads up. Those are the two considerations we're having. Any questions? Thank you.
And so just for clarification here, to just make sure everybody, you know, the budget here, the $2.6 million was in the public health block grant, the last biennium. So that is coming out now, and it's line item for diabetes. So that the block grant we know is going to be reduced by the 2.6 for diabetes.
Yes.
Okay.
And we will be painting this with a broad brush. I mean, things that you do for obesity, things that you do with outdoor trails. In my opinion, anything that decreases obesity is going to be helpful for preventing diabetes in your community. So we're going to try to make it as flexible as we can, but we still have to track this and report back to the legislature how that money was used. So we'll give you as much flexibility in using this in your community. Yes, ma'am.
When it was carved out, was it assumed that every county or every health department would be doing something, or was it carved out and taken out of the public health block grant as a choice? Because if you're going to do it as an RFP, but yet the legislators or whoever did this just don't think everybody's going to do the same thing.
It doesn't address it at all. It just says it will be used for diabetes. So we're trying to figure out, do you spread that money and give everybody just a little bit so you can't do very much? Do we find communities that are very interested and robust and wanted to do that and give some of it to them and then a smaller amount to the people that aren't very active to do training? Was something that Gary and I were talking about this morning. We're trying to figure out that
whatever we figure out the best way is not gonna make everybody happy, but we're trying to get input and try to figure out how can we best use this. We want to use however it's used, is they're being used in an evidence-based program. We found this out with breast and cervical cancer thanks to Rwanda. You know, there were some breast and cervical cancer coalitions that were buying pink pens. You know, and they aren't doing that, but I'm just saying we want to be sure that when we do report back, we can say the money was used with these programs on these evidence-based kinds of protocols, and this is what our outcomes were. So
yet everyone is going to lose money, but there may be only a few then that are able to get it.
Well, and I doubt that we would take every single penny and do it with RFPs. That decision just hasn't been made yet. So I just want, yes.
Are you focused on the incident rate of diabetes across the state
I think,
at all? I mean,
yeah, I
if
think.
you do an RFP, I mean, I'm not sure that that's.
And when I say RFP, I don't want people to panic, because we RFP, or actually we RFA, we gotta change that wording, because there's some big fancy, Allison knows the difference, there's some big fancy thing, the difference between RFA and RFP, so we're doing the easiest one. But, you know, we're looking at a very short, I think the colon cancer one was 8 pages long. You know, we don't need Shakespeare. We just need that the people are aware of what their incidence of diabetes and what their burden is in their community and what kinds of things they'd like to do. So we may not even do an RFA, but we're just throwing that out as that might be a way for us to be sure that these funds are being used in an evidence-based protocol that we can collect that outcome. So yeah, you're right. If we spread it around evenly, there's some areas that need it more than others. If we just do an RFA, well, you're right. Some people won't get anything for that. We don't know, because of the tracking system, we don't know how people were using it over the last biennium completely. So this will be a way that we can track that, and we'll try to spread it out as painlessly as we can. But there's always winners and losers.
Dr. White.
Yes, ma'am.
This is Thursday. I mean, we're waiting on the fact that we're not going to have budget till probably maybe the middle of May, and now we're talking about RFPs, and our budgets have to be in by June the 30th, don't they? So, I mean, are we kind of, when would that go out? Are you going to wait? Do you know that funding, so could that process go ahead and move without the budget?
Yes, that process is already, meeting was held this morning. We're going to be meeting more on it this week. We want to get some input from Scott and some of the executive committee as we go forward. We're getting our ideas together, and then we're going to bounce them off them and see what kind of response. But yeah, since it's not, like I said, since it's not a huge thing we're asking people to do in return, we don't see this as being a lengthy thing we're going to be sending out. So I don't know. I'm hoping within the next 2 weeks. You'll have something out by then. Once we figure out what we're going to do, but we haven't completely figured that out yet.
So for those of us who've always, I mean, we've been very active in diabetes. Of course, we're #1 in incidence in the state, in Floyd County, and close to last in the health rankings. So we have been throwing a lot of local dollars at that. So could we expect through this maybe we could get some support back for diabetes? We took a huge cut when we lost the DCOE.
I understand. Yeah, I couldn't answer that question. I would certainly hope you do because of your history of your work, and I think that's what you would put in your RFA.
Okay. All right. Thank
your
you.
Your history of how you've been good stewards of the money in the past. Anything else for Gary? Heart disease, stroke, osteoporosis, arthritis, asthma. Anything else? All right. Thanks, Gary.
Thank you, everyone.
Jacqueline, you want to come and talk about IT stuff? And Alzheimer's disease. Jacqueline and Dr. Mayfield visited with Western Kentucky University the other day and met some very enthusiastic students. Good morning, everybody.
First, I'll just give you a little bit of information on our trip to Western Kentucky University School of Public Health. Dr. Mayfield gave a presentation to the public health students, and 2 of the students came up to her after the presentation, and they are sponsoring or participating in an Alzheimer's bicycle ride across Kentucky. Actually, it's going to be across the nation. They, let's see. I actually left they have a schedule of stops that they're going to be making throughout Kentucky, and I'll go ahead and send that out to Scott if you want to distribute that to the committee. And Dr. Mayfield wanted that mentioned that it's a young organization and they're working hard for Alzheimer's. They're not affiliated with the Alzheimer's organization, but they are working hard to raise money through this ride, and I'll include more information in that email. Okay. Okay, and then I'm going to also give you just a really quick update from SDG Blue. And as you know, SDG Blue is the vendor that's been retained by the cabinet to assist with the selection, assessment and selection of an EHR vendor. I'm going to give you a quick update on their timeline. The request for proposal is out for review. It should be delivered to CHFS by April 25th. And it will be released to the public on May 20th, so you might want to jot this timeline down. It will be released on May 20th. The first round of questions and answers is between May 20th and June 19th. And the RFP scoring is July 20th through August 4th. And the contract award will be August 19th.
Question on the scoring process. Since health departments are going to be the primary users of this, is there any conversation about including some local health directors in on the scoring committee?
I'll take that back to the steering committee. I'm not involved in that, but I would assume that would be, I have to.
We would appreciate, you know.
Yeah.
Yes, please.
Absolutely. Yes.
I'm not sure, and I know that I'm not the only one back here. Could you clarify what you're talking about? I'm sorry.
This is the RFP for the electronic health record.
Okay, okay.
I'm sorry. So this is the RFP that's been out.
Okay.
Yeah, put the project on hold for an RFP to be developed.
And so now my understanding, if I'm correct on this, but we've regrouped and DPH is putting out the RFP. The contract will be through DPH instead of going through a local health department as was previously discussed.
Yes, correct. Yes, the last time I was up here and told you what we were going to do, things have changed. But we are doing the shortest RFP possible with 30 days is the shortest that you can do that. So, okay, all right. Thank you. Brandon, do you want to come up? And Brandon will be our lead now on Kentucky Health Now. Just like he's been working with the ER super utilization, he's going to be working with Kentucky Health Now. I was just talking when you were coming up.
About that? No. Okay. Sorry.
We talked about
it. Is Gary still?
Yeah, oh yeah, Gary's still there.
Okay.
I mean, Gary's just he's up to his armpits in other alligators. So, so we are spreading the wealth. So Brandon's going to be doing it.
This is a little bit late, so I'm going to read it to you, but if you recall, we had asked the governor to do a proclamation for Public Health Week, and Sarah Wilding had did this for us and had asked CADA and KPHA to help with that, and she did it well in advance, about 6 weeks prior to the actual event, and we just got the proclamation back signed last week. So I'm sure they get thousands of these. So I did want to share it, though, because it has some nice words in it. It is nice that it's acknowledging what we do for public health. So, proclamation by Governor Beshear in the Commonwealth of Kentucky, whereas improving the health and well-being of Kentucky's families and workforce is one of the Commonwealth's top priorities, and whereas state and local governments, businesses, schools, nonprofits, and individuals are challenged to take meaningful steps towards this goal in their communities, and whereas national, state, and local health departments and private agencies play a major role in increasing awareness about health, about issues important to the public's health, and whereas Kentuckians need and deserve health care coverage that is accessible, affordable, and accountable, and whereas strong public health systems are critical for sustaining and improving health, as numerous chronic diseases and lifestyle indicators can be improved through their policies and clinical services, And whereas National Public Health Week is April 7th through the 13th, 2004, and Public Health Start Here is the theme. And whereas Kentuckians are called upon to observe this week by helping our families, friends, neighbors, coworkers, and leaders to better understand the value of public health and to adopt preventive lifestyles. Now therefore, I, Stephen L. Brashear, Governor of the Commonwealth of Kentucky, do hereby proclaim April 7th through the 13th, 2004 as Public Health Week. So, a little late, but did want to share that with you, that it was acknowledged, and that we celebrated that week. And also wanted to take the time to thank everybody for attending KPHA. If you got to come and letting the staff come, hopefully you had a good week and you learned new things, and your staff got to learn new things that came back to your agency that will help you as you move forward. So.
Kathy?
I apologize. I asked late for just a few minutes on the agenda. I wanted to bring two things up to you. One, as Marvin mentioned, we've changed our FAB accreditation process a little bit. We've kind of backed up slightly. One of the issues that we're running into, and probably at the local level you did too, as you worked on accreditation, is in Domain 6, there's a lot of discussion about the laws, the public health laws, and since that's mostly environmental for the most part, we are trying to address some of the foundation type things of how do you review your public health laws and how do you get better laws on the books. So what I wanted to throw out today, just to kind of, this is very preliminary, this is just in the beginning, but we are going to try to put together a group of local health departments and state staff to have a committee that looks at our laws and our, not really I say laws, I'm saying in general, but regs. Okay, yes.
We already have that group. Thursday Sloan is the chair of it, so whoever from the state that you all want to add to that would work really well. We have Renee Blair, Nancy Cruz, Denise Bean, Teresa Hunter, Ken Costa, Steve Bean, Ron Horstman, hey Ron. But to do that very thing, I mean,
Okay.
it would be total and complete duplication to put together another group when
Okay.
this one is doing that very thing.
Okay, so that is through CADA.
Yes.
Through CADA.
Our strategic plan, but part of our strategic plan when we presented it a month ago, I guess, or whatever, at DPH was, once we got going, to partner up with DPH, so.
Okay, and I apologize, because I really wasn't aware there was a work group already doing
Well,
that.
you wouldn't have known, but I was
Okay.
saying, here,
Well, I appreciate
we're
that.
talking, let's do it.
Sure, no, I think that's a great idea. Yes, Nancy.
Kathy, I think putting an environmental voice on this group would be very good. We've come across, we've got some ancient environmental regs
Yes.
out on the books in my county, and Marvin and I have talked about it, that, yeah, they're still in force, but we don't use them a lot. And it would be really good to have some top-down guidance from you all about setting structures for doing these things, taking them back to boards of health, and that can be brought under to this committee.
And I would agree with you, because I think the environmental, and obviously that's my perspective coming here, is that a lot of our regulations, not necessarily the statutes, because I think obviously the statutes are tougher to change, but the regulations we could certainly work on. And I apologize that the regulations haven't kept pace, actually, but part of the dilemma, if you will, is once you open a regulation, you open it up to a lot of scrutiny. And so, and quite frankly, we've been hesitant to open some of our regulations because they're always controversial, you know. So again, if this committee already exists, I would ask that we have some environmental voices on there. Now, obviously, some of your directors probably have more of that type of background. I didn't catch all the names, but certainly we'd like you all to be looking at regulations with regard to environmental particularly, because that seems to be where we're really struggling with some of the accreditation process. How do you routinely evaluate and update regs? So
Kathy?
just wanted to throw that out there. Yes, ma'am.
Hi, this is Sarah Jo. I participated in a review of the swimming pool regulation and also the tattoo and body piercing regulation, and that really didn't go anywhere. That's been a while. Are you all going to scrap that and start over, or will you use some of that?
No, we are planning to use it. It is still with program staff, and I haven't got a
it's on their list of things to do. Certainly with the pool regulation, that was also had a lot of stakeholders involved, outside stakeholders, not just health department. Tattoo, not so much. I really thought we would already have that promulgated and put forward, and I haven't seen it yet. So it's on their to-do list. I apologize. I know we drug our feet. Okay. So, but we appreciated the input. It is there, and the only thing we're waiting on the tattoo is really just the submittal. I think it's finalized, but I haven't seen it. So, any other questions about the regulations, about our thought process? Okay. And again, I did not know that there was a work group, so again, we apologize for duplicating anything.
No,
but
that's fine. You didn't duplicate anything. We're just having this conversation now. We're on the ground. We need to make sure. I will type your name down on that group.
Okay.
And Thurston will get a hold of you, and whoever else needs to be on there will go with it.
Okay.
Is an environmentalist, so we.
No, I think that's a great idea, and I think if we can all work together, I think that obviously is the best thing. The other thing I wanted to throw out is just to make you aware of something that's going on. We are looking at, I guess we're in discussions right now with Lowe's and Tractor Supply. I don't know if y'all are aware of this ongoing issue or not, but for many years we have regulated retail markets, okay? And retail market definition is very broad as it's written in the statute. This would include places like Big Lots that we have currently got under as retail markets. So we are looking at that because we're being challenged by Lowe's and Tractor Supplies, and rightly so in my mind, about why do we want to regulate them. So again, we're looking at that. We are we're talking with legal on what the legal answer is, and we're also looking at what other states are doing. It's sort of all over the board. There's not a consistent answer, so it will be what Kentucky wants to do probably, because there's not a national standard exactly. So we are looking at that, and some questions have gone out to your local environmentalist. We realize that you've got to do everything on risk base and resource level now, but when you stop regulating certain places like Big Lots, you may still get the complaint when they get mice. So there's a balance, and we're trying to strike that balance or figure out where we're going with that. So I just wanted to throw that out there because you may see some email traffic back and forth, and food is looking at the policy right now, or looking at the law, and trying to make some decisions going forward. Okay? Any questions about that?
Do you know what kind of time frame you have on that?
Well, we're meeting with legal today, so we're hoping soon, although we feel like probably to get, once the decision is made about what the program and what legal advises, then we probably would want to run it through leadership, because either way you go, you're going to have some pushback. If you say we're not going to regulate you, that's wonderful, but you do need to work through what does that mean? What does that mean for the ones that you've regulated up to this point? They will no longer be regulated. We've got 3,700 prepackaged stores in the state of Kentucky. Of that number, I'm guessing about 500 of them would no longer be regulated. It's not a huge impact on local communities either way, but it does make a difference on how you proceed and what it looks like. You have to work through that because their current permit goes to December. So anyway, any questions about that? Didn't want to muddy the water with that, but I did want you to know, because I thought if we send out an email 2 or 3 weeks from now and I hadn't mentioned it, it might catch you by surprise.
Question. I know we talked about after legislature was out, we were going to be reviewing fees.
Yes, and it's actually, the paperwork is on legal's desk. Part of it is. The actual reg itself has been sent up, but we have to do a memo. The fees are being raised. Obviously, they're probably still not going to fund this program completely. It's a $15 million tax input. There's no way you can raise the fees $15 million and get it through. So we are looking at trying to raise it a very decent percentage, and again, we're looking at risk. We're trying to say, what does that service actually cost to do? So, it's there. It's being, we're waiting for the legislators to leave. Because you don't want to open up a fee reg this time of year when they're still here.
Yeah, that's one thing that I've obviously not been around up here a long time, but when I was in a meeting when Secretary Haynes said, let's figure out what regs are getting in our way and blow them up. I mean, if we're trying to do something and the regs is keeping us from doing it, let's get rid of it. And for old timers, you never heard anybody say that. You never mess with anything. She is having, I think about every 4 to 5 weeks, a reg meeting where when she signs a reg, she sits at a table, her legal person's on one side, and if it's one of our regs, Dr. Mayfield's on the other, and she goes through it page by page, and she has all the other people in the department or the cabinet are represented at the table to be sure that it's not affecting somebody else inadvertently. After she signs those regs, then she goes through all the regs that are being worked on. Again, to try to make sure that a reg we might do might not be harming DCBS or behavioral health. So it doesn't come to that day she signs it and somebody says, oh, are you kidding me? That's going to blow our program. So she's watching. She's making sure, because she has a year and a half. And I think she wants us to do a lot in the next year and a half, because she says she's out of here at the end of a year and a half, and when she closes that door, she wants all this stuff cleaned up. So I think the urgency is there with everything we do. So I think you're going to see regs going a lot faster because that's what the top wants happening. And so we're being motivated to do that. So that's pretty exciting. Is there anybody from lab here? I didn't see anyone. Or Effie, with Dr. Humbaugh not being here. They're not doing much in this. I'm just joking. Joy is not here today because she is having the Nurse Executive Committee. They're meeting right now, and they're working on the CCSG. So they have lots of good work to do. They've gotten all the input, and they're starting to look at those, and I would normally be at that meeting, but I wanted to be here. So you'll be hearing, well, hopefully 1st of June, we'll be sending that out. Yes, ma'am. Sorry? Oh, that's right. This week is National Lab Week. So if you have lab people, you need to do a little happy dance with them this week and recognize what they do, because we can't do what we do without them. So there's going to be some celebrations here in Frankfurt, but we do want to make sure that all of our lab people appreciate us. And I just found out this morning that tomorrow is Administrative Assistant Day. So just in case you didn't know, I didn't know, so now I know that I need to do something tomorrow. And AFM, I think I saw Mike. There he is.
Touched on budget, but I can remind him also of that day.
I did it in such a nicer way.
So I'm not going to talk about budget. Dr. White covered that good. Just want to remind you all that tomorrow is your contract training, LHD contract training, and it's from 9:30 to 12. It's ITV. There's limited space if you want to come to Frankfurt and be there in Frankfurt. It's Conference Suite B at Frankfurt. So it's on first floor. So again, limited seating. So I'm not inviting you because I want you to come and not have a seat, but there is some space if you want to be there. But I encourage you to stay home and do it through ITV. It's much more cost effective for you. So 9:30 to 12 tomorrow, LSD contract training. Do you all need anything from me besides this? Because that's what I have for you.
I probably should have asked.
Man, I'm almost at it.
I should have probably asked when Marvin was up there. But in regards to the NCH coordinator, is there any discussion on that? I mean, is that looking at staying the same, or, you know?
I think, Marvin, I want you to address that because I know that's been looked at, Randy.
We still plan to have funding for MCH coordinators because of the feedback that we've had over the last year plus. What we're working on is a number of different, I don't know what the right word to be here, would be strategies that you all could choose from. I don't don't know the exact number. It may be in the vicinity of 10 different strategies that you could choose from so that you could tailor it to your community. It's possible that one or two, maybe just one, would be something that we would want uniformly across the entire state. Perhaps that would relate to infant mortality. Does that get at some of your question?
Yeah, I was just wondering if you were looking at changing the structure of it.
Yes.
You know, what the delivery was going to be
Yes.
on it.
And what we've noticed too, with feedback from you all, is, and maybe this isn't a good analogy, but a lot of the health departments seem to like and felt like they were doing well with sort of the, and here again I'm calling it the package, I forget the right term, like we do with community health promotion. And so we would write something up as a description. You don't have to write a whole lot up. Basically, you would fall within the guidelines of that, and you could be able to pick from certain ones. You're welcome.
All right. Allison? Allison's still here. Okay. Sorry, I should have called her. Any other questions while we're waiting for Allison to come back? I think we've covered all of our divisions. No. Next meeting is May the 22nd.
It's,
Election day.
yeah, it's actually the week before because of Election Day, May the 13th is the next CADA meeting. We did have a question brought up, well, I guess Allison would be the one for that too, though. Kentucky Spirit, was, yeah, in a while there that, because there was a balance that was owed and all this stuff there. Is that lawsuit, any update on the lawsuit that you all have had?
I've not heard it in any meeting, but I might not be in the right meetings for that, so Allison may or may not know something, but we can do something. If I don't write it down, I won't remember to do something. So the status on the Kentucky Spirit, okay? You know any status, Allison, on Kentucky Spirit money? Have you been? Yeah, you're up, Allison.
Sorry. Phone always rings up first.
Okay, so I'm here for the fun part. I'm here to give you the Title X grant funding updates. You all, CADA executive staff sent a letter to Clara Cobb and the OPA staff, and they are going to respond to you directly. But with us being the actual grantees, we had a conversation with them. Dr. Mayfield was on the call, Joy, Clara Cobb was on the call, Edie Richards, make sure I get everybody here. Susan Muskowski, who's the deputy director, Alice Betancourt, who's the director of the Grants Management Division, so a whole lot of people there at OPA who have the power to tell us, DPH, as the grantee, what we're supposed to do. So we have memorialized this into a letter that we've sent to all health department directors and the other folks at OPA so that they know we communicated with you what they told us to do. We've also CC'd that to the chair people of the local boards of health. We're getting all kinds of phone calls from all over the place. So we want to have a consistent message that covers everything that we've been told to do. So here is the short story of what you're going to get. This is the letter. It outlines the 4 most important things that they told us as recipients of the grant. The first thing is that you cannot base access to family planning services on immigration status or on county or state of residence. Doing so is a violation of their grant rules. I don't have to explain to you all that any violation of any of these rules that they place on us as the grantees could lead to us having to give the money back, much less losing the money that we get in the future. And we don't want to be in that position. The second thing that they told us is that you're not allowed to provide limited services in any location. So if somebody comes for a family planning visit, every service that they might need has to be available unless it's a complex sterilization, IUDs, implants, things like that, that you can contract out with an OBGYN, anything above and beyond sort of your general family planning services need to all be available at once. So if anybody's doing a partial service at one place or another partial service at another, OPA says that that is against their rules. We cannot, if family planning services cannot be based on income levels, you can't require that they meet a certain percentage federal poverty guideline. Obviously, they also encourage you to bill insurance or Medicaid of anybody who has that, and hopefully that helps to cover some of the costs, but we can't base it on income when we give them the services. And then finally, anything that we do, and I think we might have run afoul of this for sure in the past, anything that we do to change our providers, to change our programs, you all have to send us a letter, and we have to send it to them, and they have to approve it. So any changes in your family planning program or what you're using your money for or how you're organizing your program has to be approved by them. So these are the rules as they've given to us to communicate with you. If you have a corrective action plan that you're not signing, that you're refusing to sign at this point, that's a big problem that we're going to have to answer to. And alternatively, we're going to have to come to you. If we have to repay that money, we're going to have to come to you to get it. So please, if you have any problems with this, feel free to call me. I don't have a whole lot of control over it. I'm just a messenger. They're the ones with the money. We have to do what they say. But if you have any questions, let me know. This letter is going out to everyone, and not everyone is, having any of these problems or any of these questions, but we just wanted to make sure that everybody got the same answer because we're getting questions from all over.
I was just wondering what the response was to the statutory requirement that the Secretary of Health funds it at 90%.
I'm sorry. Their response to that?
Yes, what was their response? Because that is part of the statute, the federal statute.
There was no.
They funded at 90%.
They didn't give us.
They didn't care to answer that, I don't guess.
I don't know that was addressed in the call.
Oh, it was addressed in the letter that we sent to.
Right, and you're going to get a response to your letter, and that's what I said at the beginning. They're going to respond directly to you to your letter. This is what we addressed in our phone call with Bill. And I don't know. I was at home with a sick baby. I'm on behalf of Joy letting you all know what the phone call resulted from. It may have been addressed. I don't know that, but I don't know that was an issue that they were talking about.
I have a question.
It was in your letter.
I have a question. This is Lynn Sadler from Northern Kentucky. Did I hear you correctly? Did you say the letter was going to come to the directors and the local Board of Health chairs were being CC'd on it? Well,
yes,
why are they being CC'd? I would think that it would come to the directors. The directors are responsible for making sure that the health department's program is in compliance. If they feel like they've got an issue that, that's coming from their board, that they would then need to share that letter with the board. And for those of you who've been around a long time, the last thing I need in Northern Kentucky is a letter about family planning going to my local board chairs.
Well, because we're getting calls from them. So we're trying, not necessarily yours, and I'm not insinuating that anybody on your board is calling, but we're getting calls from all of these people.
But I think it's good for places that are not having problems. I think it has the potential to awaken a sleeping giant that I know I don't want awakened in Northern Kentucky. So I don't see the need. I think the directors should be responsible for ensuring their program is in compliance, and if their local board is raising questions or has concerns or whatever, that they need to share the letter. And I don't know how others feel, but that's my opinion.
Well, I think that your board should go to you as the director, and you should come to us, and then we should go to OPA. But that's not what's been happening. So everybody is going to be given the same information. If you're not having any problems, I can't imagine that your board's going to have any issues.
Well, and I can talk offline with you about it, but there is a history, and Rice can fill you in as well. There is a history in Northern Kentucky with issues about family planning and from the past, and I just don't want to raise any opportunity to have discussions about family planning when there's no need. I mean, we're in compliance, everything is fine here, and I just don't see the need to CC all the local board chairs in the Commonwealth.
noted. Yes, ma'am.
I just have a question. I just wondered, given this conversation and the Title X not basing access on county of residence, given that over a third of our funding formula now from the state that was revamped a few years ago, if there's been a reconsideration of that,
Of your,
the funding formula, over a third is based on the county's population.
no, not that I know of with Title X money.
Not that I know of.
I mean, I can pose all of these questions to Joy as far as how the money is formulated and distributed. I don't know.
A little over a third is the county of residence, your population. Another is your federal poverty rate. And what's the third one?
And I'm sure that's absolutely right. I don't know.
The base taxing district revenue.
I don't know if it's been reformulated or not.
It has not, to our knowledge.
Okay.
Okay, I don't know.
Yeah, is it going to be?
Okay, yeah, I thought you meant your family planning, well, you're talking about the block
Given
grant.
that our allocations, which include
Right.
are based on over a third of your population in your county.
We revisited that formula before we got the legislature as well. So I think there's going to be a revamping of looking at that. I don't know if it's going to be changed or not, but I know I had heard Dr. Mayfield talk about looking at it. But that's all I can tell you. But somebody has recognized that we need to look at that.
Thank you.
And then your family planning money that you get comes from the OPA says, okay, this grant year, we are going to look at how many people you saw last year in family planning, and we're going to give you $45 for the number of people you saw last year, which is one of the reasons we've always encouraged. You know, if people are coming in for breast and cervical cancer screening and they're not asking for birth control, count them on your family planning if you talk to them about family planning, just so you can keep them in your count, because the more people you see, the more money you're going to get the next year. That's how that allocation works. But I see what you're talking about, and I know that conversation is happening. It's not a conversation I've been in on, but I know that conversation is happening.
Because, I know in reality, some of us will have APRN available every hour of the health department, so.
Right.
Some less so.
Yes. Yes.
Can I ask you a question, Dr. White?
Yes.
I know with your Title X family planning grant, one of the goals in there was to increase the number of clients served with family planning. And with decreased funding, how are we going to be getting more money with every patient that we serve?
No, if you start billing them as Medicaid patients, because you'll get more money out of that than you'll get that $45 that you're getting from OPA. So you can bill a visit if you're providing clinical services and you're seeing them, then you can bill them as a Medicaid patient.
Yeah, I understand
Hopefully,
that,
if they're a 90-10 person 3 years down the road,
I understand that, but I just know
that's
as part of the grant process, one of your goals was increasing the number of folks that we saw from family planning.
And I think what you're going to find going forward, that number is going to go down, because more of those people are going to have a medical card and will not be in that grant
We've already
process.
seen that the past 2 or 3
Sure.
years.
Right.
By the rate of about 20% per year.
Right.
The whole state is seeing that.
Right.
So we're not going to make that money up like we expect that we're going to make it up.
One thing that we're seeing is that the people that have full coverage, such as Medicaid, they're leaving and going to the primary PCP, but we're seeing an increase in the number of insurance people who have insurance that have high deductibles.
Well,
we're seeing those, and there's nothing, they don't pay anything.
Well, yeah, and so that's why I don't understand why they would come to see you guys, because if it's a preventive service, there's no cost sharing, so they can go anywhere to get that service.
They can't go anywhere because they don't have the money to pay for the office visit.
But if it's preventive.
So they come to the health department and we have to do it free.
But no, they can go to their primary care doctor. They don't have any cost sharing. If I want to go see my primary care doc, they can't charge me for that visit if it's a preventive service.
I understand
Okay,
that.
okay, then I'm not understanding your question.
A lot of the doctors aren't scheduling them. They're
Oh.
not scheduled. If it's a service they have to provide to those individuals that's free on the preventive side, they won't schedule them. So they
based upon
end up in the health department.
So based upon Title X and our requirement not to turn anybody away. If we
Exactly.
don't get in network with those insurance
Well, you can
agencies,
still
we're
bill
gonna
that
lose money.
insurance company.
Yeah.
Yeah,
I
you'll
mean-
still bill that Blue Cross and Blue Shield, and you'll get whatever Blue Cross pays for
Yeah,
that
but
visit.
that's just, but not every
Fine,
health
okay.
department bills every insurance.
Boy, they need to.
Yeah, I mean, we're gonna lose this federal funding more and more. We're gonna have less federal funding, we're gonna have less state money. So, I mean, this is from,
Yeah,
I'm the lawyer, not the doctor, but from what I hear, this is the way we're gonna have to be able to work to make it
PPH, I
as
think,
sustainable.
needs to understand that it's a process that health departments have to go through. and
Right.
It's not something that can, a turnaround time of 30 days. We're looking at months and months to get everyone signed up, to get signed up, all the health departments, to bill all the insurance companies. So there's huge lag times where there's no funding coming in.
And we understand that, but we're not getting the funding to help you understand it. That's where the disconnect is. And there was a great deal of effort to try to explain that to the legislators. You guys tried to explain it, we tried to explain it. And obviously, people weren't listening. But yeah, it's not a free service. You will get to bill that if you are building that insurance. Yes, ma'am.
Okay, on your number 4 point where you said that we can't split up the service. Now, of course, we do with IUDs and some of the
Right.
complicated things. But in the past, you've allowed us in the last few years to send those with Medicaid or insurance to their pharmacy for their family planning. I think you're going to confuse the nursing directors when you say that you can't split up the service because of our being allowed to do that.
You're talking about the prescriptions?
Yes.
Yes, no, this is just services, so we'll be sure and add a line that says,
Yes,
this
I'm
does
thinking
not
like the
refer to,
clinic
thank you.
there.
Yeah, I wouldn't have thought of
Confusing
that.
when you say you can't split up the service because.
Okay.
But what we mean by that is,
Some we give their contraception there, and then the ones with Medicaid and insurance, we send out, and I'm afraid you're gonna make people think that they can no longer do
prescriptions
that.
are part of the services.
Yes.
What I think, some places, at Clinic A, you can get, emergency contraception and pregnancy tests, and that's it. And at Clinic B, you can go here and get this, so you have to have all those services in each location rather than making people go to Clinic A for this service or Clinic B for this
And I
service, but
get
not
that,
the
but I think
prescriptions.
that would be.
We'll be sure and put a disclaimer on that when we send that out. Yeah, I was here when Women's Health, when we first came out with, if somebody has insurance, write them a prescription. Don't use your expensive resources of your stash of birth control pills for those folks. And so, yeah, that's a good point. Thank you for that. I wouldn't have thought of that. Appreciate it.
If clinics cannot afford 100% of the roles, do we have to obligate ourselves to it?
To the Title X money?
Yes.
I don't think so at this point. Now, how that's gonna work, whether family planning is gonna be part of your core block grant, where it's, you get it all or you get nothing, whether it's gonna be you can take this state money, but you don't have to take this federal money, I don't know yet. But I think ultimately, we can't make you take the grant. How that affects the general fund money and the core block grant, I don't know yet. That decision hasn't been made.
I know Monday, and I won't be here, but Monday, Dr. Mayfield is having another we've been strategic planning. You know how much fun that is, but there's been a lot of those kind of planning sessions going on, and that decision hasn't been fleshed out. But it's a conversation, so it is something that we're aware of. Yes, sir.
When I had the male clinic in my county, we saw about 800 to 900 visits a year. So I'm planning to open it this year, and that will add, maybe 1,000 more patients for the next year. So in family planning, they were for many reasons, counseling, condoms, and STDs. So there's a good opportunity to increase the numbers.
Well, and hopefully a lot of those people will have a medical card, so you can get a little bit better reimbursement for that.
Can we, also I heard that you said that we cannot bill for them. We cannot charge those people, right?
No, they don't have to pay you a copay if it's a preventive service, but you can bill their insurance.
Okay.
Anything else?
Yes.
Oh, I'm sorry.
Maybe my comment isn't relevant at this point, but it's back to Paula's comment and funding formulas. Just a point of information and to remind folks that with WIC, what we do is we allocate based upon prior service levels. And so then it doesn't matter with WIC what the county of residence is. I'm not trying to suggest how y'all do your funding formula, but at least that's one thing that we factor into ours.
All right, anything else? Happy Earth Day?
Scott, Dr. White?
Yes.
A question came up earlier about MCO contracts. Do we know where we stand with those? The MCO contracts?
Where are we with the MCO contracts? Well, and I am the right person to ask about that. We've got them all on our table, and we're working right now with their dental contractor, with public health, dental hygienists included. So we're kind of at that, I'll sign it when you get this agreed, and they're saying, well, you've got to get it agreed with them, just go ahead and sign it. I'm afraid to sign until I know we've got the public health hygienist and the telehealth in the contract. So we're this close to having that done. I had a conversation with Dr. Mayfield about that this morning as to where we're going to move on that. And Ron is in my office just about every day. Want to know if I've signed it. And so we're just trying to make sure that we get every single penny that we can get for reimbursement through that contract. And I'm just afraid to sign something that when they say, oh, we'll do that later, because I don't believe it. Sorry, I know I'm not supposed to say that on public record, but I don't believe it. Yes, Ms. Nancy.
Waiting on, in terms of the public health registered dental hygienist, what is a long title, how close are we to getting the protocols on that to take to our local public health?
Oh, I thought that had already been sent out, so let me,
I don't think we have them out in the field. We don't have signed that I know of. I mean, maybe you sent them out and I've missed it.
Okay, I'll check with Julie. I may be incorrect, so I'll check with Dr. McKee and find out.
We're getting ready to want to do MOUs, MOAs with our school systems, and
right.
And we explain to them there'll be a big change once those protocols are signed.
Mm-hmm.
So if you could follow up on that, I'd shoot.
Absolutely, yeah. If I write it here, I don't usually lose that piece of paper. So, but yeah, and we want to make sure that when you roll that out, you're going to be able to get paid for it. And so we're doing. I'm sorry. That's pretty important too. So, so that's my commitment is trying to get that paid for. Someone else had a hand up. Yes.
Back to this Title 10. Maybe I missed something that in code, but anyway, we get a certain amount of money from Title 10. They listed all the things we cannot do. We cannot provide limited services. We can't bank it on income. But do we have to exhaust, after we've exhausted the federal dollars that we have, do we have to continue to see people even after we've exhausted those dollars?
Well, you're asking the wrong person since I'm an OBGYN doctor and I'm very passionate about that, but I don't know legally.
It's not that I don't care about people, Dr. White, but we have to be realistic.
Oh, I understand.
We can't put hundreds of thousands of dollars into a program that, for me, I get about a third of what I spend.
A lot of health departments are putting, it's 50-50 for some of them. They're putting 50% of their dollars to keep this program working. So as a public health and OB-GYN person, I'm thinking, okay, where am I going to put my dollar to get the best bang? So I'm going to think family planning, and Marvin's going to say prenatal care, and so everybody's got their own personal passion. But I don't know, if you run out of money, do you stop the service? I don't know the answer to that.
I can ask.
But
I mean, again, I'm just the messenger. These aren't Allison's rules. I'm more than happy to take back any,
If you run out of the money, then can you have your
Was it on the letter?
services?
Okay, well, good.
It was on the letter, so I'm hoping that they will give us a response.
I mean,
And they said they were going to respond
Yeah.
directly.
And that was the whole key to the letter there was, we've been having conversations ongoing for a long time, and it's like, okay, for 2 years, we have had funding, the block grant funding, when we went to that concept, that's when we saw, like Marvin was saying, instead, utilization was not a factor in considering how money was to be distributed then. And so once utilization in our clinics, you had some clinics that were net gainers that had a lot of patients coming from outside sources. We've got health departments down on the Tennessee border that they cross over, that they come to get services across the state line even. And you're seeing, and we're hearing back from Tennessee where they say we take whatever dollar amount we get from family planning, we divide it by 12, and we give that much services each month. And that's how we limit. So I think this was a request here. Okay, we previously, through mutual conversations, had been led to believe that it was an acceptable practice to limit based upon geographic service area who we provided services to. We were not denying services. We were referring them back to the health department in the jurisdiction in which they lived to get their service. And so if that is not an acceptable practice, what are acceptable practices? Because we do not have an unlimited source of funds to do this.
Well, and we know geographically what they have to say. I mean, I know a woman in Campbellsville who went to a health department. It wasn't Taylor County. It was a different health department where closer to where she lives, and she was told even though she had cervical cancer in the past, she couldn't get Pap smear because they were out of money. Come back in July. So I don't know if you can do that with family planning, but if that was in your letter, then that should be addressed in the letter.
And that the letter was asking there, give us guidance on how do we limit resources or limit services in an acceptable manner, because we do not have unlimited resources, and some of our health departments are struggling.
And I think even this issue about not partially doing services here or there, I think that came as something that we did not know. I mean, I think there are some places that have been doing that with our full, understanding and support, and we didn't know that wasn't something they wanted us to do either. So you're learning a lot of it as we're learning it, and I don't know if it's because there are such fewer dollars that they're really, cracking down on the rules and how we use it.
And again, this is not a cabinet opinion, but where we really got hit was back when birth control pills were 6 cents a pack, and you woke up one morning and they were $16 a pack. I mean, there are people that were here when that happened.
Yep.
And so that just, and there was no more money given to you when that happened. So that severely cut how much services that you could do when those pills went up. I don't know, do the math, like 8,000% or something. So I understand you got a lot of problems to try to figure this out. So all we can do is tell you what the feds tell us has to happen, and then help you figure out how to make that work. She was first, and then you.
Well, ironically, one of the things that we had cut back on was our diabetes work in the community to help pay for cancer and family planning. So now you're taking, funding is being taken back. And
we're not taking it back. The legislature is.
Okay.
Oh, that's a big
I'll
difference.
tell you why, because the legislators say
we had to cut back on something.
Yeah.
So we didn't want to cut diabetes.
Sure.
But we cut back on diabetes to help fund family planning and cancer. And now that's being taken back and earmarked for diabetes, so that's going to cut family planning and cancer more. And then in addition to that, my undocumented population is rising that are not qualifying for the Affordable Care Act. So my prenatal program is rising, which also takes out of the same pool of funding from family planning and cancer.
Right.
And the reason for that is that your legislators say, well, this Affordable Care Act that the governor signed without asking us first, everybody should have insurance, so we don't have to worry about this. And it's not true. I understand that. But that's what the people who are giving us the money, this is what they've got in their heads. So you're right.
Line to zero.
Right.
So we're getting no reimbursement.
And I don't know if that's a cabinet position.
I'd like to do everything.
I'm sure that's probably not a cabinet position, but it is true.
It's written in the budget. So.
You weren't on camera when you said it, so that's a good thing, right, Ellen?
Georgia, did you have something?
So Rice left, I'll be him.
Stand on the chair.
I want to say it's the canoe thing. That was him, right? I thought her name was the canoe thing. No side of my canoe, no side with him, whatever. So I want to make it known I'm on the side of public health, everybody, not DPH, not LHDs, everybody. But what I'm hearing loud and clear is decisions are going to have to be made, hard ones. And if we continue to do what we're doing, there are health departments that are gonna be broke. So broke in that the door does not open. So I don't know who, at federal level, local level, state level is gonna be pissed about that, or who's gonna fix it, or whatever, but that's the reality of the situation. Does the state, the legislators feel like the things that are rolling down, the boards have to step up and pay that? Because I know the local politicians feel much differently than that about it. Regulatory, does the state, will they step in and take over a health department when there's no more money? Or how's that work? But when one shuts their doors, Title 10 can do whatever they want to, but there'll be no service there at all.
That's right. And I think that's why Dr. Mayfield has been saying, I know at least as long as I've been around, which isn't very long, but we've got to figure out ways to be sustainable without depending on money from the feds, money from the state. We've expanded Medicaid. There's no match. These are services that you can set up to bill for, be more like a business and less like a local health department has been in the past. And it's just a shift in the way things are done. And I know that's been said at least a million times in the 7 months I've been here.
The kicker to that, though, is not like a business. Our overhead is at 50% or so. It keeps us from competing with the local doctor's office or Walmart or Kroger or whoever. I mean, we don't make money doing that.
Right, no.
And every time a Medicaid patient walks through our door, it's lost, no matter what. Because it costs us more to deliver the service than we're ever going to get reimbursed for. So the model that I'm hearing is that try to find $1 to fund public health instead of we need to find what is public health, not a private health service, it's a public health service, and that needs to be funded. And so suggesting that we provide more Medicaid services isn't going to fix our leaky boat, because every time they walk in, if we can do 100 and the staff it takes to do 100, we're still going to be in the hole every time they walk in the door. So trying to generate more private health services that are being paid by a third-party service is not a sustainable model. It's just not. And then we're losing the true public health focus by doing that, by trying to find that dollar.
You've also got to watch primary care and what that entails, because they keep saying do primary care. Well, are they talking about urgent care, acute care, or primary care? Because it keeps saying primary care. That involves 24/7 availability. That involves emergency care, and that involves either doing or contracting hospital care. So what is primary
Yeah, and nobody said everybody needs to do that, but just.
I mean, I think that's something that needs to be looked at. Are you talking about primary care or the kind of Walmart clinic concept?
And that's one of the reasons for this survey. If somebody's really interested in primary care but doesn't have a clue how to get started, if there's 1 or 2 or 3, then we'll work with that group. If nobody is, that's fine too. Marie, I'm sorry.
I'm sorry. I've read its topic, Medicaid match. But my question is, are we going to continue to pay the full fee on family planning services for the match, or is that going to be reduced in line with what
The 90-10, no, from what I understand, the 90-10 going forward.
I mean, is it going to be?
Yes, going forward. Now, Medicaid's set up to do that, from my understanding.
Yes, that's correct.
Okay.
I think Commissioner Kistner said that
At the last
I was
meeting.
here, but I
I have a question.
Yes, and then.
We look at some of our state regulations, we talked about that some of them may be outdated and may actually be contributors to the local health departments not being able to make it anymore. When we look at some of the federal level things, my question is, does DPH have the ability to advocate and educate on behalf of the local health department of why some of these federal guidelines or laws are not sustainable at the local health department level anymore?
Every opportunity we have. I mean, it's not, what you're saying is not falling on deaf ears, it's falling on the ears of people that can't control what happens in Washington or Atlanta. I mean, we go to them, we explain, we express, we try to let them understand, but they only have so much money as well. So everybody's reinventing themselves as the boat is leaking. You're absolutely right. And I agree, Allison. I mean, if we had funding to give you, but what we're trying to do right now is figure out with what they're taking from us at the state, we're going to have less to give out.
I completely understand that.
And
I guess the message that I'm not communicating well is that if it comes down to what we really are statutorily required to do, those 4 things, then that's where our tax dollars, our money, that's where it should all go. And, you know, it might be a health department of 2 people, but we're statutorily required to do those 4 things instead of adding additional stuff to us that is still not going to fund what we're statutorily required to do.
And
So,
evidently,
I kind of feel like, you know, if we're going to talk family planning, we're going to talk breast and cervical, which are all wonderful programs, but the moral imperative is that we can't afford to do them, and we're letting our real public health statutory mandate thing that we have to do slip by the wayside because we're pouring money into a program that, you know, doesn't line up with the governor's Healthy Kentucky. You know, none of these programs that are lost leaders, or not even lost leaders, are, you know, draining local health department budgets. Don't line up with the Kentucky Health Now initiative.
well, I think the 4 new things are actually 4 things that aren't really new. They were things we were supposed to be doing all along, and they just hadn't been well articulated. Is that core service going to be changed? I don't know. That's what's in consideration right now. I don't know the answer to that question. One.
I was just kind of food for thought on this. I think local health departments have more power than we recognize, because when you accept those allocations, what you're saying is you do the service, but it doesn't define to what extent you do those services in terms of the volume. So there are ways that you can get in and look at your numbers and your projections. You can project, with this amount of dollars about how much service you can do, and then you can control your appointment schedules to spread that out throughout the year. And you can look at it at mid-year to see. You can't always predict the amount of average rounds you're going to have in your kids' school program, but you can get around ballpark figure and make that adjustment to the appointments for the last 6 months of the year. Because having worked at KDPH before, as long as those dollars are being spent the way they're supposed to be spent, and you're able to justify that, you're going to, like the kids program, you're going to be reimbursed based on those services you're providing anyway. So the fact that you're not going above and beyond and putting extra tax dollars into that, theoretically shouldn't be affecting that allocation. It may impact your family planning dollars the next year because you're getting X amount of dollars for patients you see. If you serve less patients that year, you might get less dollars that next year. That's a decision that departments have to make in terms of projecting how many patients you want to see in future funding. It's food for thought.
That kind of creates a conundrum, because, obviously I'm going to make appointments for my WIC patients first, because they're paying the whole bill, and then the rest of the appointments that I have, I'm going to leave those open for family planning and breast and cervical cancer. That's not the way that I heard the Title 10 presented, but, we only have a certain capacity to serve. We do only have a certain capacity.
My stepdaughter calls me the czarina of public health, so she obviously doesn't understand what I do. And if I could fix it, I know lots of ways I would fix things for you folks if I could, but I can't. So that's why, again, for the phone calls, if you've got ideas, if you've got stuff we haven't floated out there, let us know what we can do. We're trying to find more financial input. I went to an Appalachian Regional Commission meeting the other day and was real nice to this guy, and he's got money he wants to give us for some diabetes work. I went to a conference on telehealth, and I think there's ways that we can bring and generate some income with some telehealth, not more than just a facility fee. But you're right, Marie. It's going to take a while to get these things revved up. But they even took our color printers away from us, so I can't even print money at DPH now. We have one color printer on the floor. So I can't do that. All I can do is the best I can figure out, but need your help if you've got better ideas of ways to do it, I hear what you're saying, Allison and Georgia, but I don't know what the answer is. So please, I think the working together in the strategic planning committee is at least the best start we've got. Okay. Well, happy Earth Day anyway to everybody.
Thank you so much, Dr. White and team.
Okay. Yeah, we'll just, Jacqueline is gonna send out that timeline on the RFA, RFP, RF whatever, RFEHR for y'all, so you can have that.
And when should we expect that family planning letter? Has it already been
The
sent
one
out
from us or the one from the feds?
from you all?
Yeah, ours went out yesterday.
In the mail, in like snail mail.
Should be in the mail.
Right. I don't know when the feds are going to send theirs. They told us 2 weeks ago that they are going to specifically, I mean, I'm sure it comes to Scott since it was addressed from Scott, but specifically respond to that letter directly.
So you might want to give your Board of Health a heads up that says, you're going to be getting a letter, but it doesn't apply to us, just throw it away. That's what Nancy needs to do. Okay.
Okay,
Thanks, guys.
thank you all so much. I've got a closing item here today. I would also like to ask Ms. Paula Alexander to come forward. Yeah, get your exercise. A good friend of mine, I served on a chair of a board, and I was vice president, and he always said I was in charge of vice. So, Paula, we appreciate you being in charge of vice for us here with CADA. But I appreciate your friendship, your dedicated work to public health, your service to CADA, and just a small token of appreciation, just something to hang on your wall, use as paperweight, you know, put in your pod box, whatever there. But just in appreciation on behalf of CADA, we wish you nothing but the best, and just to feel honored to call you a colleague for the time that I have. So thank you.
I just have to say from out, I've adored you all. I've talked to Judy. I said, latch on to CADA. They're your lifesaver, and you all have been, every one of you all, including you all, to me. I couldn't have survived today being a director without you all, colleagues at DPH. I don't think a week's gone by which I haven't sent out an email. It's like, well, what do you all do about this? Could I look at your contract? You all are wonderful. I'm not leaving Kentucky for good. We're keeping our home here. We'll be coming back 3 or 4 times a year. My family's here too. You all know that. You are all welcome to come near Albuquerque. We're not out, don't live actually in Albuquerque, but 30 minutes in the high desert. Open invitation to everyone, and please take advantage of that. When I change my phone number and email, please don't cut me off. Don't cut me off on Facebook or all that. So, love you. Thank you.
Thanks, Paul. Bugs Bunny always was supposed to say, I knew I should have made a left turn at Albuquerque. Wasn't that it? From the old cartoon days. Okay. So again, best wishes and thanks, Paula. So, motion to adjourn. Thank you all so much.